So I don't know anybody here, so I'll just introduce myself, and then I thought I could just get a feel for who you guys are as well, and it's always good to meet her. Yeah. So my name's Samantha, but I'm definitely Sam. I don't know why my mother called me Samantha. I've never been that, just as you were saying. And my background is in herbal medicine, and previously in the UK did some nursing. So moved into herbal medicine for various reasons really. I have 2 children. I've got a 26-year-old son, Ashley, and then I've got a 2.5-year-old son called Johnny. So Ashley was bothered with eczema and asthma frequently as a child, and I started to just delve into that side as a very young mother, because I was only 17 when I had him. So by 19 I was starting to ask different questions on what I was conditioned to know and access, as in the medic side. And so I then went off to do massage and then reflexology, and then I just started to question working in nursing that one man in particular had Parkinson's disease. He'd been taken into hospital to have his medications reviewed, and I just remember that they just made an absolute mess of him, and I remember feeling quite frightened for him and questioning, well, why can't we giving him massage to help reduce those terrible spasms that he had as a result of his Parkinson's. And so then I moved to Ireland and got involved in doing vega testing, which is an energetic field of allergy testing. And then I moved to New Zealand 17 years ago and did my degree up at South Pacific College, and then have gone off to do my postgrad in health science, looking at complementary medicine has largely been my focus, obviously. So I've done bioethical papers looking at the healthcare strategy and its benefits, or its beneficence as they call it, for all the good of healthcare for individuals. I've argued that point because of the medical paradigm which it works in can't possibly practice beneficence when they're only using their one model of healthcare. So I argued the use of complementary medicine. And then I won a scholarship, and I went off and did some research in the use of women using complementary medicine in breast cancer and why that was, and that was quite an interesting exercise. And then I've done motivational interviewing for behavioural change. So we are taught as students to be prescriptive. In my experience as a clinician, I've got my own practice, it generally doesn't work. So you're better to allow the patient to be autonomous and allow them to elicit their solution themselves. And so I think as soon as you can get into that type of practicing, the more successful you will actually be in your clinical practice. Because if you're just giving a prescription and telling them to do something, you have got no idea whether that's possible for them to do that. So it's better to use what motivational interviewing actually does is it uses the self-perception theory, so that when I hear myself talk, I believe what I hear. And so that's what you're trying to do, is just to elicit what they know, because we're all intelligent individuals, aren't we? So I did that, and then I looked at Pharmac and why it wasn't using St John's wort as an antidepressant instead of using SSRIs and SSNIs and tricyclics. So I looked at the whole monoamine prescription process that is dominant in New Zealand and argued the use for using St John's wort. And I'll talk about all of that as we go through. And now I'm doing my Masters in Health Science. I'm looking at health and environment. So that's my interest in research is autism and the environment. So looking at glyphosates, which is Roundup, and the incidence and prevalence of autism in New Zealand, which is growing exponentially. And I don't know if you know Stephanie Seneff. I'll talk about her as we go through the presentation. She's an amazing professor working out of Minnesota, and she's done this longitudinal study looking at the prevalence and incidence of autism in children in the United States. And rather alarming stats that back in the 1960s it was 1 in 400, then in the 1980s 1 in 150, currently it's 1 in 68 children will be born autistic in the United States. And she's hypothesizing because of the growth that's been seen, it's not a bell curve, it continues to grow, is that 1 in 25 children in America will be autistic. And that is to do with the concomitant use of glyphosates in our food, and also the adjuvants in vaccines. So it's not the vaccines itself, it's the adjuvants in the vaccines. It's the mercury and the aluminium and the other metals that we use to bind and stop it going off essentially. So that's a little bit about me. I'm still an apprentice, still learning. Every day I learn something new about patients and herbal medicine. Yeah, so you just never stop learning. You've chosen an amazing career, but you, as well as practicing in it, you have to be an advocate for it, and you probably already recognise that that's what you have to do. So, yeah, so I'll start with Morag.
Cowboy?
Yeah.
No,
yeah, what's brought you, so what's your name, what's brought you to be a naturopath?
Children.
Yeah.
Having kids. I used to work as a nutritionist, and it just wasn't enough. I found a lot of my clients, a lot of it was counselling more than anything. There's all that other stuff going on. And then I kind of left the field and went into the field. Well, I went back into doing more work with horses. So now I'm trying to combine naturopathy and horses and
Great.
yeah.
Fantastic. It's totally possible. There's a few folk in New Zealand doing that. So
Yeah.
Yeah, good. Good. Thank you. Hi.
I'm Leah Morris. I'm from our brand. We have a lifestyle blog. And I've got into naturopathy because our daughter, who's nearly 23, has got severe chronic fatigue, fibro, endo, and is an invalid. So that is why I'm doing this.
Oh, good.
So I'm looking forward to your talk.
Yeah. Oh, good. I hope you get something out of it then. I'm sure you will. Yeah, some of this is cutting edge research, so it's very, it's up there. So.
My name's Morgan.
Hi.
I'm from Wanaka.
Yeah.
And years ago, in my early 20s, I'm looking for some direction. Thought, maybe naturopathy, and thought, no, it's too airy-fairy for me, and didn't actually look into it. And then all these years later, I met Liz Jury, a previous student, and a women's retreat, and became friends, and went home and looked at the website just to see her picture.
Yeah.
And then while I was there, I thought, well, I'll look at the curriculum. And then bells went off in my head, and I thought, this is what I want to know about the body and those sorts of modalities and how to help people with nutrition.
Good.
Yeah, so that's brought me to here.
Here you are. Very good. Hi.
Hi, I'm Maxine. I'm from Tikawata, which is north of here. I did reflexology many years ago, and then we moved to New Zealand, so I started working. I'm an industrial chemist. I have a master's in chemistry, so I did all that, but I just hated industry and nothing more anymore. And this was a good way to do part-time while I was still working, because I always felt with the reflexology I wanted to go further. Like, you know that someone's kidneys or whatever weren't working, but I never knew why or what to do. So yeah.
Oh, good.
Hi, I'm Sarah from Auckland, and I've always been interested in herbs and plants. I remember when I was young, I used to think that I wish I knew all about what different plants did and different herbs did. And I decided to get into it because I wanted to use it with animals, but I thought it would be good if I learned it with humans first, and then later on I could go on to that side, and I found it really interesting with the human side. So, yeah.
Good, thank you. Hi.
I'm Holly, and I'm from here, from Trinity.
Yeah.
And I got into this because I'm really into gardening, and I used to always think, I wonder what a big plant does, and I thought, that's quite interesting. And then I was like, I want to know about more the body and the mind connection. So you get sick, and then you get like antibiotics or something, but then I find that I've been still sick afterwards and not really fixing it. So yeah, I want to get to the cause of stuff.
Good.
Yeah.
Hi.
Hi, I'm Karen. I'm from Taronga. I've always been interested in natural health ever since I was trying to be a nurse for my sins, mental health nurse at that.
Yeah.
Been in the job 20 years, still am a nurse. Got into a bit of strife when I realised that a lot of the presentation wasn't being addressed, and a lot of aspects of mental health. Patients are actually side effects of medication, and then I've got into some strife for making patients better through talking therapy. Didn't go down too well with the docs because they wanted to shout their meds. And then carried on my journey and decided after my second baby was born to learn naturopathy, because as if I didn't have enough time. And then just started studying, and I'm really lucky that I work co-papa and I'm actually allowed to integrate my training into my nursing practice. And I've got mental health clients who've been in the system for 20 years, and those that come on board and run with it are getting better, and their physical problems are getting better as well. And it's just a blessing to see those clients, the changes they make and all the hard work they put in. It's incredible.
Yeah, that's right, and the commitment that they make to getting well, because first they're understood for the first time. I've got a real passion for mental health and especially schizophrenia and borderline personality disorders, so fascinates me.
And the spiritual element is left out completely.
They just did a really interesting piece of research in New York on schizophrenia and companionship model for rehabilitation and getting better, and the outcome is phenomenal, absolutely phenomenal. And schizophrenics often are living in isolation because they're so scared of the world and scared of people, and if you do a companionship model, it shows to be very, very effective. And it's all about love, isn't it? It's just about giving love and sharing love. Thank you. But you're not from Tauranga though, are you? Are you from
Can you tell? When I was in England, I worked in Birmingham, but always lived on the outskirts of the West Midlands.
Oh, nice.
Yeah, so it's a bit of a shift for me.
Yeah, cool.
World turned upside down.
Thank you. Hi.
Hi, my name's Rihanna. I grew up in Christchurch, but am currently living in Western Australia. And I don't know, like Karen, natural therapies have always been a large part of my life. I really loved doctors as a child and things like that. And my original passion started in herbs, and I started studying herbal medicine, and the college shut down. And the only way for me to continue with that via distant learning was transitioning into naturopathy, which I do love and I do really enjoy. But I've also studied Ayurveda, and the Eastern model probably vibrates a little bit stronger with me than the Western, but I live in the West, so kind of have to have the comprehension of both. I don't know, it's just a really awesome foundation to probably build everything else upon as well.
Yeah.
It's a nice encompassing foundation.
Oh, good. Thank you.
Yeah.
You've gone a long way.
What's that,
I'm
sorry?
all the way from Western Australia.
Yeah, but you know, I'm a Kiwi and my family's here, so.
It's an excuse to come home and visit. Awesome. Dirk, we briefly met, but just a little bit more from you would be good, yeah.
Okay, well, my name is Dirk. I live for the moment in New Plymouth. And obviously, as you know, I'm not part of your class. But I'm starting the third year in June, and they invited me to come and listen as well. My interest in my studies in the things that I did, I traveled a lot. I'm still a tour guide as well, partly. And I had a lot of contact with African healers, North American healers, Aboriginal healers, and so I, from when I started traveling, I have always been passionate about healing and about spirituality, and my spiritual studies have led me to understand that you have to know thyself before you can really go any further in those things. So that has led me to try to lead as healthy a life as possible, which my wife and I do together.
Yeah.
And so that's the reason why I started late in life, studying naturopathy, but I've already been doing that on my own for decades.
Yeah.
I just wanted now to make it official.
Yeah.
Get the ticket.
Yes.
Yeah, that's right, past school. Yeah. Good, that's great. Hi.
Hi, I'm Michelle, and I live in Wanganui, 2 hours away. And I was sort of introduced to alternative stuff as a teenager. Because my mum spent 3 months in bed unable to move, and the specialist couldn't help or anything. So in the end, my parents found a witch doctor in Taranaki, and took her along, and by the time she left his place, after probably about an hour and a half, she was walking fantastic. And so I sort of saw things then. And in my married life, my husband woke up one morning and couldn't walk, couldn't move, and ended up having 2 spinal surgeries. The doctor said they'd never touch him again. He was told he would never walk again. He would never, they did everything. He would never be able to work again or anything like that. So he wanted to get off the painkillers, sorry. And nobody could sort of seem to be able to help him at all, and he wasn't one to give up. So we found a local gentleman who was an energy healer who worked with him, which sort of really opened me up to the whole vital energy field. This guy was just mind blown, but that's a whole other story. And he kept saying to me, well, you can do this, you can do this. So that's when I sort of started learning about spiritual healing, energy healing, and built on that. Also became a massage therapist, because that always helped. Ended up doing the Reiki as well, so I'm a Reiki teacher. And then I just found that clients were always, so I was always operating and telling you everything. They'd always say, so I've got this wrong, what should I take? And, although I could come up with suggestions, I didn't really feel that I should be, saying you should take this without actually having the know-how. And I sort of thought the way the industry, the world is going, you're going to get sued one day for telling somebody to take something, especially if you don't have a qualification. So.
And they're very complex. Herbs and nutrition are very
Exactly.
complex molecules, so you actually do need to have a really good foundation to know what you're recommending.
So I thought for my business, it would be better overall if I could give them an informed.
Awesome. Fantastic. That's great. Hi.
I'm Natasha. I'm from Golden Bay. When my youngest went to primary school, I got a bit more time on my hands, and I thought, oh, what shall I do now? And I always had an interest in naturopathy, so I just took it up.
Good. So everybody wants to practice, do they?
No.
Everybody wants to go into clinical practice. No.
No, I don't think so.
You don't.
I want to work in healing centres, maybe retreat centres or something like that, but I don't think I want my own clinical practice. No.
Right. Okay. That's all good. It's all good. Just so we've got third years who have just gone into third year.
Last September.
Last September. So we've got varying levels of knowledge in the room, haven't we? I pitch my stuff technical because that's how I'm hardwired. So you're going to leave here feeling challenged. That would be my hope. But I also encourage you, because you're not going to remember and know all these pathways that I'm going to talk about. You'll know them, but you're not going to remember them, and that's okay, because I've spent probably about 100 hours with this research. There's about 300 research publications, which by and large are 26, 30 pages long. So I know it. So you have to pick me up on things that you want clarified. Okay, so it's a learning setting. So I encourage you to do that. And if you've got questions, please, anything to interject, please do. It's what we're all here for. Is we're all here to learn. So today we're going to look at the first half, looking at chronic fatigue syndrome, and I'm going to set the scene of what chronic fatigue is and various approaches that you can take. Because I'm a herbalist, not one size fits all, and I will refer back to this, that patients are called patients for a reason, because not one size fits all. Mostly your patients, you bring in with some information and knowledge about what you know. So if we get philosophical, you can view it from an ontological perspective, which is we know what we know because of our conditioning. And then you look at the phenomenology of the patient, is that they're coming to you with what they know, all right? So together you've got a knowing and they've got a knowing. And often you're sitting in the chair with your patient going, oh man, this is tough. Because we're often last resort practitioners, okay? So I call myself a resort practitioner because we are last resort, that's just the truth of it. They go through medicine and then they come to you, and by the time they come to you, you're an absolute mess. So You're often pilot studying with your patients. They probably don't teach you that in college, they didn't teach me that, but every single patient is a pilot study. So Mexican valerian might work for one patient, Valeriana officinalis might work for another, Cava might work for another, St. John's might work for another. I mean, there's so much I can talk to you about, but we just don't have the time. But everybody's a pilot study. But essentially, when we're looking at chronic fatigue, there are common denominators that we can look at, and I'm going to discuss the principles and the concept of a mosaic disease. Has anybody heard of that before? Yeah. It's a beautiful way to formalise what naturopathy actually is, and so we'll get into that. Then the second part is we're going to be looking at fibromyalgia, and I'm going to be delivering some real key research that's coming through on neuroinflammation, so inflammation of the brain that's feeding into fibromyalgia and its concomitant or comorbid conditions together with chronic fatigue. So they're mosaic diseases in that different parts make up the person to express chronic fatigue or fibromyalgia, but those different parts or those different tiles have varying, massive differences, all right? So if we look at chronic fatigue, it's only in the last 10 years or so that it's actually been recognised by the Ministry of Health in New Zealand, and that was through lots of battling from chronic fatigue individuals. So there is a paper now available on the Ministry of Health, and it's between 3 to 5% of the New Zealand population are actually affected with chronic fatigue, and that's reported cases, so there'll be guaranteed people still suffering in silence. Lots of men won't self-report to doctors. Men are not so good in reporting their medical conditions. That's just a given, so they're hardwired. And it's not until they've got, say, a woman in their life or a sister or a mother that will egg them and push them to go to the GP. So roughly about 3 to 5% of individuals. So it's complex, it's pervasive, and it's debilitating. Now there's over 1,000 papers on this topic. Largely you can access them through PubMed, you can read their abstracts, but over 1,000 papers, and they're probably in the vicinity of around about 30 years those papers have been published. Lots of them are randomised controlled trials, which is quantitative analysis. We're more interested as naturopaths. We're interested in the stats, so we can sound smart when we talk to doctors, but we're actually really interested in qualitative data. So I'm very interested in looking at a case study series, which is looking at each person as an individual, not truncating their story, but getting their full picture to identify where are you in this mosaic. Okay, so are you genetics, are you your environment, are you your diet, are you your loss of spirituality, are you exposure to toxins, whatever, are you that baby in utero that was exposed to excessive amounts of stress, and so you start to then build your own picture. So yeah, if we go back to that 1,000 papers, there's plenty of literature on it, but I'm going to present you with some of the latest stuff this afternoon. So I'm going to invite you to think about the practical aspects, because you're all now going into clinical practice. You're seeing patients now on Wednesdays. Is that right? Yeah. So what happens if you're remote from the college? How do you see patients?
We're only seeing one while we're here, otherwise we see your own.
We find it all in there.
Oh, you do it in your own areas, and then you report back that way. Okay, so when you're seeing your patients, I invite you to think about the concept of the mosaic disease. It was first coined in about 57 by a chap called Irvin Page, and he used the concept for hypertension. But it wasn't just blood vessels, it was far more involved in the process of hypertension. I mean, you've got the TH gene, for example, will make somebody more susceptible to white coat hypertension. So if they see a stethoscope and a sphygmomanometer coming towards them, because they're hardwired, they've got a genetic disposition to have catecholamine release, excessive catecholamine release, which is your adrenaline and your noradrenaline, and so that will cause them to be hypertensive. So he first coined the phrase, and then Schoenfeld coined it again in 1987, and he coined it around autoimmunity. So I think if you look at all disease, all illness, through the construct of what a mosaic is, then you're on the right track. So if we look at what's in a name, even giving chronic fatigue a name has proven difficult. It was called sophicases in the 19th century. Then it was called atypical poliomyelitis. So we're starting to get a bit more of an idea. Myelitis, something that's an inflammatory response going on. Oh, it's when you touch it. Better not touch it. Then in 1950s it was called the Royal Free Disease. There was a bit of a epidemic in the UK which referred to this benign myalgic encephalomyelitis, which is what we coin it now essentially. And then it was called myalgia nervosa, epidemic neuromyasthenia. So they're starting to get an idea that the central nervous system's impacted. Post-viral fatigue syndrome is another one. Chronic fatigue syndrome, which is what we largely know by now, with chronic fatigue syndrome in New Zealand, and I know that in home in Scotland is coined ME still. And it was believed to be all in the mind, essentially, because there isn't any diagnostics for chronic fatigue as we know it, but we'll go through that there actually is as we go through this afternoon's presentation. And then last year it was coined systemic exertion intolerance disease. Now that cost about $3 billion to rename that, and was published here by the Institute of Medicine in the United States. So they wanted to redefine the illness. So, you know, $3 billion to redefine what something is called is neither here nor there if you've got chronic fatigue, is there? So it would be much more useful. So in response to this intolerance and exertion, they've come back, people from the chronic fatigue, members of the Chronic Fatigue Institute came back with insulin systemic pancreatic insufficiency, definitely reduced orgasm or penetration, or death, disorder in which everything appears to be found. And I thought that was pretty good actually. So if we look at the cause and defining the etiology of chronic fatigue, from a medicine's perspective, is that it actually just completely baffles them, and they still do believe in some patients. I certainly see some patients myself still who just don't know what's wrong with them. Blood tests all being done, referred to a psychologist or a psychiatrist, or you're just depressed. I've got half a dozen young women in my clinic at the moment with chronic fatigue from the Gardasil vaccine, and one of them actually can't walk unaided without crutches now, and so she was sent to a psychiatrist because all the blood tests came back normal. And they tried to report it, and it's interesting, of those half a dozen women, they've come in with their mums, they're between the ages of 16 and 24, and they've come in with their mums, and they've tried to ask, could it be the vaccine? And they've gone, no, couldn't possibly be that. And so two of the 6 have actually gone through Otago Medicine to medical school to report the adverse effects. But they've been blocked. So it's a very interesting process. That would be a good research to get into that. Very interesting process in the what would you say, I don't know what you would say about that. I just don't understand it.
Actually, there was somebody asking a question about this on our school Facebook page. I was wondering if you had anything off the top of your head where you know, articles or things that were online.
Well, there'll be information on here. I'm not into publicising in social media, so I just don't. It's not professional of me to do so. I think if people are interested in that, the information is massive. There's a lot of literature out there, there's a lot of new research out there, there's lots of publications, there's lots of books. You just literally have to read them. Because I can tell you my view of it from my perspective of the world, but my perspective of the world might be slightly skewed to yours, so then you might interpret it a way that becomes not my truth. And so then that becomes the truth, because it's your truth. And so it's better for people to read it themselves. I really encourage people to do that because things get skewed.
It's not then just the writer's truth, though?
Well, it depends. If you read Martin Heidegger's book on truth and correctness, he's got an interesting slant on that as well, but we're going off track. But what I'm saying is that if you want information, like what you're going to get delivered today will give you enough information to go back to your friend, but they have to go off and read it themselves.
It's our school, the college Facebook page, but
Yeah.
someone's asking for articles or to be pointed in the right direction to find that sort of stuff.
Yeah.
You're not asking for the information.
No. But there's information in there. So if you look at the references, that there's annotations within your references that will discuss neuroinflammation, which is largely what's going on with people having adverse reactions to vaccines. And it's and we're knowing that as well. There's a publication put out back in 2010 around sudden infant death, and they physiologically have the same response when rats are injected with mercury and various vaccines. They have atrophy of the spleen, they get atrophy of the brain, identical, absolutely identical presentation. So that's what is likely happening with SIDS. But of course, we're just on that path. So there is a poor understanding, go back to this, poor understanding of the disorder comes from the varying clinical diagnostic definitions as well as the broad array of body systems from which it presents. And essentially what this paper is saying is we haven't got a clue what's going on and it's not one cause and effect. And so we know with medicine that it likes to truncate what's actually happening. So I've basically discussed Irving Page very briefly. It's quite an interesting paper to read, as is Schoenfield's paper here as well. And so I'm interested into delving into this further with Christchurch and children who have got post-traumatic stress disorder as a result of the disaster. And if you look at the global research around trying to measure children with post-traumatic stress disorder, it's largely done by adults, surveying methods, and so there's nothing qualitative about it at all. Yes, we need to measure and get an idea of where that person is, but because often these surveys have been adapted from adults to children questionnaires, they're closed questions, and it's yes, no, and what you often find is that the parents will want to self-report, but because it's a quantitative study, there's no room for, we weren't expecting you to write that on the questionnaire, and so they don't have any measuring processes to acknowledge or qualify the qualitative stuff that's come through in self-reporting. And so if we look at this concept of a mosaic disease, we know that it's the genetics that I talked about earlier, it's the environment, it's the food, it's environmental toxic exposure that they've been given, it's about previous childhood adversity. There's some studies showing, all studies biased of course, there's some studies showing that children who have had childhood adversity are more likely to be depressed and have conditions like chronic fatigue. It was once thought that if a child was sexually abused, these are just nonsense research papers, to be honest. These are psychologists out to try and prove a point that there has to be one cause and there has to be one effect. And of course, chronic fatigue or any disease is not one cause and effect. And it's like using this, I like this analogy that I use with my own patient, is that, okay, you've got life, it's a 1 litre jag, if only it was that basic, but you've got 300 mils of emotional stress from how you respond to the world, you've got 200 mils of financial stress, you've got 400 mils of work stress, then you've got 200 mils of sleep deprivation stress because you've got 3 children under the age of 5, and you're functioning on 2 hours sleep a night and wondering how you're not functioning in the world, because you should be, because you're a woman. And I'm not a feminist by any, if I came across this, I'm not a feminist. But it's now you're at 1.1 litres, and so that's just enough to tip that person over the edge. And so then your patients will say, but I've always been able to eat gluten. And you're like, yeah, but just because your body was always struggling, and if you look back to their childhood case history information that you've collected, is that you can see that they always had ear infections or skin problems, and that was the body trying to say, okay, I've reached allostatic load here, I'm not coping, and so this is what this mosaic concept is about. It's very naturopathic. So we need to formalise this a little bit more and do more research around it as naturopaths to prove that point. So a mosaic disease principle is looking at a syndrome or a disease which differs in expressions but has common factors, i.e. pieces of the tile. So we've got this Roman chap here with the terracotta tiles, each displaying a causative factor in the disease. Or we might want to make it into a fish, change the tiles around and make it into a fish, so it's the rheumatoid arthritis, but similar factors going in to create that disease. So what we like about this, which is very naturopathic, and this is your domain. I mean, for those of you who want to go into clinical practice, it's an honour, it's difficult, and it will be how you make your money. Okay? So this is where you can pay your rent just by looking at the principles of this disease, and even treating chronic fatigue. I mean, if there's 3 to 5% of the New Zealand population with chronic fatigue, that's a lot of people, and often they've had it for like years, decades before they come to you. So what we identify with this principle is that each patient is a unique picture. It's a stochastic combination of causative events or factors. Medicine doesn't like this because it's so random. It's not rhythmic. It just can be all over the place. And the patient's story is paramount. So we're not going, okay, you've got headaches, you don't sleep very well, you've got some gastric complaints. Oh, I know, you're depressed, and we give you an SSRI. So they're truncating it because of the model in which they work from. And these people are good people. They've gone into medicine because they genuinely want to help people, and it's the model in which they believe in, so it's their truth. But it's a 7-minute medical model which, by and large, is compromising lots of choices for people. So we don't truncate the story, the patient's story is paramount. So when we look at the 3 P's of causation, we've got predisposing, which can be an example of genetics, precipitating, which can be pathogens, and perpetuating, so what's causing that maladaptive stress response. So which one of the 3 do you think it could be?
All of them.
All of them. Yeah, that's right. It's all of them. So remember the 3 P's. This is another lovely way of looking. This is a parable that was put out, and these are these 4 blind wise men. So this is this chap with the elephant's trunk, but it's an elephant's trunk, and it feels like it's a big snake, and so therefore it's a snake. And then we've got this chap over here saying, well, actually no, it's not a snake. It's it feels like a tree stump. And then this chap over here is going, well, it feels like it's a big sheath of leather. And then he's going, no, you're all wrong. It's actually the tail. It's a mouse. And so if you look at little parts and isolate them, then that can be the truth, can't it? But if you bring it all together, of course, it's an elephant. And so I think this, it's on Wikipedia if you want to go and have a blind man in the elephant parable. It's a good little story just to be able to pass on to your patients if nothing else. So the definition of chronic fatigue is something that we're largely held in ransom to because there are no blood tests for diagnosing chronic fatigue. So we've got the Holmes definition in 88, the Fukuda definition in 1994, we've got the Canadian in 2003, and then of course down to 2015 you've got the US Institute of Medicine who have just changed the term of what chronic fatigue is. Of course, it's that exertion intolerance, systemic exertion intolerance disease. So if we look at the Fukuda definition, which is largely used still, you've got to have severe fatigue for longer than 6 months and at least 4 of the following symptoms. And of course that's the headache of a new type of pattern or severity, multi-joint pain without swelling or with swelling, muscle pain, post-exertional malaise for longer than 24 hours, significant impairment in short-term memory or concentration, sore throat, tender lymph nodes, and unrefreshing sleep. Now, one of the differentiating factors between chronic fatigue and fibromyalgia is how their HPA axis works. So when you've got a chronic fatigue patient, they are, what do you think? Because they sleep so long.
I'm fatigued all the time.
Yeah, so they've actually got down-regulated HPA axis, versus a fibromyalgic patient, they've got excessive HP axis. So what we're seeing with these patients, and this is cutting-edge stuff, we can measure it through their cortisol awakening response, shows significant variances between those two groups, is that, so we want to focus instantly with chronic fatigue or fibromyalgia, we must focus on the HP axis. So with a down-regulated HP axis is the chronic fatigue, which is why they have that unrefreshing sleep. Even like one of these girls I've got with the adverse vaccine effect, she's sleeping up to 18 hours a day but still really tired. Okay, so just completely exhausted. Versus a fibromyalgic patient can function on 3-4 hours sleep because their HPA axis isn't actually shutting down.
How about when you get people with both diagnoses?
I think because it's a spectrum, isn't it? So it's for you as a naturopath to determine from their symptomatology if they go hyperinsomnia or insomnia. And hyperinsomnia is generally a fibromyalgic patient, and insomnia is generally your chronic fatigue. So yeah.
Excuse my ignorance, what is the HPA axis?
The hypothalamus pituitary adrenal axis.
Can you repeat that?
So it's the hypothalamus. Shall I write it down?
And could you just repeat, it's downgraded, did you say? Downregulated.
I'll repeat stuff.
Okay.
I will repeat stuff, but the HP axis is down with chronic fatigue and it's up in fibromyalgia. So. Pituitary. And this whole HPA it goes like that, hypothalamus, to your pituitary, to your adrenal glands, and then it produces your stress hormones. And so your hypothalamus produces your adrenal cortical releasing hormone, your pituitary releases your cortical releasing hormone, and then that tells your adrenal glands to produce your adrenaline and your noradrenaline. I don't know what you call it now, but that's what I call it. You call it epinephrine and norepinephrine, depending if you've got Maria textbooks, that's what she'll say. And then of course your cortisol.
What was the CRH then?
Cortical releasing hormone. Yeah. So HPA axis is key in looking at these patients. So this is another case definition. This is from the Institute of Medicine 2015. And we've got substantial decrease in function. So can you see that there? It's not quite showing the full screen, is it?
No, it's very tiny.
It's very tiny. It's very silly. It should be 2 per page, shouldn't it? I can't even read that. Oh, it's just patient presenting. Sorry, it's been a while since I've done this here. So they've got substantial decrease in function. Yes, go down. No, go across. Persists for more than 6 months, which is one of the criteria. Yes. Post-exertional malaise and unrefreshing sleep. Yes. Cognitive impairment and orthostatic intolerance. We're in a counter-orthostatic intolerance, which is hypotension. Okay. And then it's when they go from sitting or lying to standing up. One of the most severe side effects is called POTS, and so I'll write that down because we will come to that. Tachycardia. Syndrome. You frequently see this in young girls with chronic fatigue. It's called POTS. So it's postural orthostatic tachycardia syndrome. Okay, frequently seen in young girls with chronic fatigue. So anyway, they've got that issue with blood pressure, and then they get diagnosed with chronic fatigue or ME. Okay. So I think in terms of looking at the diagnosis, you're best to look at the Fukuda, because the Fukuda at least acknowledges that there's some kind of infectious process that IOM doesn't. So this is the mosaic that we're going to look at. So we're going to look at the additional things that can present with a chronic fatigue picture. So we've got the psychological, often comorbid with depression and anxiety, often because the quality of life is compromised. Okay, mood swings, panic attacks. We've got neurological problems, so we've got balance problems, seizures, numbness and tingling. And then we've got that immune problem with the chronic cough, allergies, frequent infections. Now more often than not, these people are actually Th2 dominant, so they've got excessive cytokine production going on. Then we've got there's often a gut component as well. So when you're looking at a chronic fatigue, this is the 4 things. These are the quadrants that you need to be looking at, okay? Diarrhea, constipation, nausea and cramps. And it's interesting, no matter what they eat, no matter what you cut out, no matter what you introduce, this is very, very tough to get a hold of. Get a hold on. There are many, many more symptoms, but those are just some of the common ones. So fibromyalgia is comorbid with chronic fatigue, as is irritable bowel syndrome, as is migraines, and as is Zika syndrome as well, which is an autoimmune condition. We've got fractures, and it's possibly because of that orthostatic hypertension. So they're falling down more. We know that there's vitamin D deficiency in some of these individuals, but not all of them, so they're more prone to fractures. We've got the multiple sclerosis. Now, this is very interesting because multiple sclerosis has, and you can see the inflammation in the brain with multiple sclerosis, okay? And the same with chronic fatigue syndrome. We've got anxiety and depression there as well. So it's a really interesting condition in terms of like how it affects all body systems, doesn't it? Nothing seems to be immune from it. So if we look at the occurrence of chronic fatigue, this has been done across various countries. We won't labour too much on that, but essentially the summary of it is that throughout the different countries, globally, there is an incidence of 2 to 3%, but it's been far more than that, because if you look at how they're diagnosing it, and they're telling lots of patients then that, well, actually you don't fit any of these categories, you don't have 4 of the 6, you might have 3 of the 6, and you know your bloods are all normal, so therefore, bye-bye, you don't have it. And so they go off and suffer in silence and go and find people like us, and we go, well, actually no, I reckon you've got chronic fatigue. And even just for them to hear that can be quite an emotional journey for patients, a massive emotional component attached to it because they've been suffering from compromised quality of life for such a long time. Risk factors, we've got infection and a history of infections, we've got stress and physical abuse, female reproductive issues, seems to be more females than males. However, that's probably because females are far better reporting health issues than males, so this is purely speculative. This particular piece of research is just speculative. Personality and coping factors, so we know if you, how you respond to stress can have an impact on whether you're going to get chronic fatigue or not. And then of course age, so we're seeing more and more younger girls coming through with chronic fatigue than we ever have. And that's just an annotation of the references that we've just covered off. So, key pieces in the mosaic, given that we looked at that quadrant, just previously we're going to be focusing on immune and infection, any kind of stress responses, the brain and nervous system, so as you were saying, Sarah, healthy mind, healthy body. You said that, you're Sarah, aren't you?
I'm Holly.
You're Holly,
Yeah.
sorry Holly, you're Sarah. Yes, sorry. And then one of the key things we want to look at is mitochondrial function. Now, when you have chronic fatigue, because of the neuroinflammation that's going on, you will always have to focus on mitochondrial function. Always, it's number one.
Because of the what inflammation?
neuroinflammation, and I'm going to come to that. So it will all come together, and if it doesn't come together, we've got time at the end to help it come together.
Okay.
Alright? We've got plenty of time. So, looking at immune infection, we know that there's a pathogenic response to chronic fatigue, but of course, not one size fits all. So, glandular fever might infect one person, West Nile fever might infect another person, what else? Coxsackie virus might affect another person. So, then medicine goes, well, it's not viral because it's not the one virus, but it's a combination of different viruses or bacteria that can feed into that etiology in the first place. Toxic plasmosis, yeah. I've got a girl at the moment with toxic plasmosis, very unwell. Massive lymph glands. I was thinking, oh my god, it's nothing too sinister, but it's toxic plasmosis, and so very high levels in the blood, almost 4 times what they should be. Not good. Immune imbalance and deficiency. So what we see happening is that we've got this overactive immune response that goes on, and I'll talk about this when I come to a landmark study that was done in Australia last year, is that the immune system gets itself into the state that it starts to chase ghosts. And so we need to start thinking, well, how can we balance that? How can we switch that off? And so one of the key herbs that we know works for switching that off is echinacea. And echinacea is the alkaloids mimic cannabinoid receptors. And cannabinoid receptors, of course, are from cannabis, but alkaloids mimic the cannabinoids. And we have got CB1 receptors in our brain, and we've got CB2 receptors in our brain. So they're cannabinoid 1 and cannabinoid 2. So echinacea binds weakly to cannabinoid 1s, and it binds very strongly to cannabinoid 2s, which is what modulates the immune response. So echinacea is wonderful for just supporting and regulating an immune response, whether it's too high or too low. It seems to modulate those CB2 receptors. So for those of you that want more information on that, just get in touch with Proherb, and we've got CDs and all sorts of literature on that if you want to get some more data. We're resource heavy, so we've got lots of stuff to share for your education purposes. So we've got excess cytokines, plasma, and the cerebrospinal fluid. So how do you measure cytokines in the cerebrospinal fluid? How would you measure cytokines in the cerebrospinal fluid? A lumbar puncture. It's the only way you can do it. And we know that if cytokines are in the cerebrospinal fluid, they're therefore in the brain. Okay. And cytokines are not supposed to be in the brain because the brain is immunoprivileged, and it's largely an innate immune response. It's not cell-mediated, which is what cytokines are. So you've got this excess cytokine production going on in the brains of these people with chronic fatigue syndrome, when actually you should just have your macrophages and your mast cells and your basophils. No, you don't. It comes with risks, but there was an amazing study that was done, and I have to take my hat off to the control group that participated in this study, because there was about 650 people that participated. There was about 320 with chronic fatigue, and the remainder were the control, and they put their hand up to have a lumbar puncture, because lumbar puncture can cause disability, permanent loss of legs, you lose the use of legs, and of course infection is one of your biggest risk factors. Encephalitis, autoimmune issues, gut dysbiosis, and vitamin D status. Looking at the endocrine stress response, I'm just giving you a summary of each of these quadrants, and then I'm going to greater detail about how to treat them. Is everybody following me so far? Loosely? Do I need to tame it down?
Brain is
immune privileged. Like the gut was initially thought to be immune privileged because 80% of your immune system starts off in the gut and the Peyer's patches. But actually what we're saying is that the brain is immune privileged. And if we think about why is the brain immune privileged?
Because they're married? No.
Yeah, so it needs to know what's going on in the rest of the body. So, you know, we've got the blood-brain barrier there, which is selective on what it lets come through and stuff. But the brain needs to know if there's danger, and so it's immune privileged. It just needs to know if there's inflammation going on in the body and does it need to direct it and what it needs to do, because it's the governing system, isn't it? So the brain's immune privileged, but it's immune privileged just with innate immunity, so your first line of defence, not your second cell-mediated immune responses, which are your Th1 and your Th2. So we've got that dysfunctional HPA axis that we talked about, and that abnormal stress response. The hypothalamus filters everything that goes on in the body, from temperature to that sun coming in through my eyes, you know, my pupils at the moment, the hair on my legs with my trousers, running from the tiger, falling out with my partner, sleep deprivation with my toddler. Doesn't differentiate what it is, it just knows that it's a stress response. And so that becomes dysregulated, and you get this changes, so you get this downregulated stress response. So we see that these people have got low cortisol levels, because this has got itself into a bit of a pickle, essentially, okay? Now, because of that neuroendocrine response, we've got the disordered sleep patterns. When I was a student, one of my tutors used to say, if somebody's in insomniac, Sam, just think, where's the inflammation? And he never could give me the rationale why that was. Because I'm like, well, why does inflammation interfere with sleep? And he said it just does. It was a phenomenon. And that was a wee while ago now, so we didn't have the research to show us why it was a phenomenon. But what inflammation in the body does is that it breaches the blood-brain barrier. So any systemic inflammation in the body, whether it's rheumatoid arthritis, osteoarthritis, Crohn's disease, ulcerative colitis, which are all on the increase in New Zealand. We've got the highest rate in Canterbury in the world of Crohn's disease. You'll expect to see disordered sleep patterns. And see, what happens is that systemic inflammation is able to send messages through the peripheral nervous system that upregulates this innate immune response to your macrophages, that then cause mast cells to produce, and mast cells instigate the release of cytokines. And so this inflammatory response actually deregulates how the brain works, and so how it uptakes neurotransmitters, how it synthesizes neurotransmitters. Because then you've got this inflammatory response going on in the brain, you get an increased reactive oxygen species going on. So, you know, you need to start thinking about antioxidants as well if you've got some kind of insomniac picture coming through. So you can start, I mean, this is all new stuff for you guys, but you can start, you know, it just gives you a flavour of what to go and read more on, and it just gets you thinking that, okay, she's an insomniac, okay, there's always an emotional component to insomnia, but what else is going on? Is there an inflammatory response going on in the body that is just causing this neuropara-inflammation? So it's not full-blown inflammation that you would see, say, in schizophrenia or autism or head trauma, for example, or stroke or multiple sclerosis. But you can measure the cytokines through the cerebrospinal fluid that I talked about earlier, and you can see that actually, yeah, there's a para-inflammation. So it's not like brain on fire, it's just like brain smouldering, kind of. It's a bit of a difference there, okay? And then of course you've got that fatigue, which is paramount to the picture. So looking at the brain and nervous system, we've got neuroinflammation. I've given you a little bit about that just now, but we'll talk about that in the second part. We've got brain changes that we can see coming through. We've got pain. We've got cognition and memory, which is actually a hallmark of any mood disorder, is cognition and memory, brain fog. We'll talk about that a little bit later. We've got sensory changes and visual disturbances, autonomic imbalances. So that's your parasympathetic and your sympathetic nervous system. You've got that orthostatic intolerance that I mentioned, called POTS, postural orthostatic tachycardia syndrome, and then you've got psychological factors there as well. So, looking at metabolism, we've got oxidative stress, we've got mitochondrial dysfunction that I talked about, we've got heart function issues. Some of these people are presenting with right-sided heart failure and chronic fatigue. It's quite scary, but we'll talk about some herbs and things that we can look at there. skeletal muscle function, and of course we've got toxicity. And there's a raft of tests and stuff that you can do for these people, which are very expensive, often inaccessible because they're expensive. But I think if you just go back to this mosaic model and give these things a try, unless you're doing functional testing, looking at porphyrins, which are a metabolite of hemoglobin and other processes that go on in the body, organics profiling, these are urine tests that are looking at metabolites that are spilling out. I mean, these are $400, $500 American dollars, these tests. They're really, really quite expensive. This is looking at the causative model. I think we can already say that we know that stress, ambition, toxins, emotional crisis, which is all part of that mosaic principle, can feed into being devitalized. You used that word earlier, vital energy. So you get devitalized, and weakened immunity, abnormal immune responses, and then you get this stalemate of autotoxicity, and that's when the immune system starts to chase ghosts. Okay. This is just another, an updated version, if you like, from the Principles and Practice of Phytotherapy. Who's got that book? Kerry Bowen's book. Yeah, fantastic resource. So this is just another example of what is actually going on here, that we've got stress, whatever that stress is, whatever the hypothalamus pours out the stress hormones to. You can have viruses, acute or chronic. You get that cellular immune impaired T and B cell activity going on, reactivation of the virus with a bacterial infection, and then you get inflammation, and then of course you get that fatigue. So you can see that it's just this cascade event, can't you? This is just another example of that sustained arousal theory, that the HP axis is it's just become dysregulated and it's not turning on and off as it should do.
So how does adrenal fatigue tie into that then?
It's
That
the
must
same
be part
thing.
of it. It's part of it.
Yeah, it's absolutely part of it,
Yeah.
yeah. And of course in medicine you're either Cushing's or Addison's, you can be nothing in the middle. And so, we're interested. I mean, often when they're doing, checking for cortisol levels, they're doing serum cortisol, and serum of course is blood. And lots of things can bind to blood and bind it up, and you don't get a true reading. But if you use plasma, like so if you use saliva cortisol, and they're also in the States now using measuring cortisol through hair, showing to give you far more accurate readings. Yeah, but adrenal fatigue and chronic fatigue are much and such the same thing. Yeah. So this is this causative model just on array. Essentially, you've just got that altered HPA axis. Good. Okay, so chasing viruses. Back in 1992, this researcher said, no, I've got the answer. It's the human herpes 6 virus, and also known as Raggedy Ann syndrome, because these people were just so lethargic and so forth. And then these two researchers here went, no, we've got the answer. These are the viruses that are causing it, and so now we need to get a drug to fix the virus. We need an antivirus. And what they'd found from these two studies, actually, they had contaminated the samples. And so everything that they had published had to be retracted. And so nobody's any further afield, except that we know that there's possibly an immune component because of how the cytokine levels have been measured in these chronic fatigue patients. So here are some of the pathogens that are involved. So we've got chlamydia, mycoplasma, herpes, varicella, Epstein-Barr, cytomegalovirus, herpes 6. We've got parvovirus, hepatitis B, Coxsackie, dengue fever, poliovirus. The list just goes on. So why does one person get infected? Like, for example, my sister went to the States and ended up with West Nile fever and had terrible chronic fatigue and managed to come out of it, but she still, if the jug reaches over 1 litre with her stress, she can be in bed for 2 weeks, so she can revert back to a chronic fatigue picture because it's It's obviously still in there. It's not so easy to get my hands on her if she's in Scotland, but yeah, it's just like looking at that whole picture. So Ross River virus, Giardia, and of course Borrelia, which is it's becoming a larger problem here in New Zealand as well. So something to be mindful of. It's like Lyme's disease and Borrelia. So if we're looking at the dysregulation of the immune system, we want to upregulate so we can see there's an upregulation of immune-driven inflammatory responses, reduced natural killer cell activity, they're TH2 dominant, increased levels of cytotoxic T cells, and they're generally more hyper-responsive to T cells than the B cells, okay? So immune system is something that we need to work on. This is just an example of, this is quite a large study, I don't quite recall how many people were in it, but it was quite significant. And it's looking at the difference between the non-fatigue people and the chronic fatigue people. And what we can see is that they've got much lower natural killer cell activity going on. So that's something that's your innate immune response. So there's been a major hypothesis in regards to chronic fatigue and its immune dysregulation. And then if we look at this recent findings here, we can see that leptin is interesting. Leptin's all part of your satiety center. It's produced by your fat cells. It's all tied up to inflammation. And we know that if somebody's got elevated C-reactive protein, for example, if you get them to lose adipose tissue, i.e. get them to lose weight, you can drive their C-reactive protein levels down just by getting them to lose weight. And what's the best way to lose weight? Exercise and diet, isn't it? So, getting them to work within that envelope theory too, because with chronic fatigue, because they're so fatigued, there's a theory called envelope theory, and that means is that when I live within my envelope energy, and you'll often see people who push themselves, get out into the garden because they want to have some kind of normality in their life, and they push themselves too far, and then puts them 3 weeks back in bed. And so you go, well, even if you don't feel tired today, I still want you to have a sleep in the afternoon. And so encouraging that they're just, because they're nocturnal and they're diurnal rhythms, so day and night rhythms are completely out of sync as well because of that HPA dysregulation and therefore melatonin levels and serotonin levels. And it's all, I mean, I could talk to you in far more detail, but I just don't have the grace of time to do that with you. But those are all things to consider, is that your serotonin and melatonin levels are all up the wall as well, because of course you need serotonin to make melatonin, don't you? We can see that this is a cytokine TH17 is often elevated, especially after a post-infection, which is where that theory of infection comes in from. And of course there's always that low grade, and these are TH2 cytokines as well. So it's important for you to know the difference between a TH1 and a TH2 for your clinical practice. This is the landmark study I was talking about, where they had about 650 people, and within this population, I think it was 350 who had chronic fatigue, and the rest were control. And they did a lumbar puncture on these people. This is in Australia, this study, so it's not too far from home, and the Barossa Valley, around that area. And they had identified that actually indeed, especially when they've just got into a chronic fatigue pattern, that they can, because what medicine has done to date is they've looked at cytokines, but they've only measured them over very short periods of time. This is done over a 3-year period. So you can start to see that they, say for interleukin 17, which is indicative of infection, is that they've got far higher levels than the control study. But they're still elevated there in after the 3-year period as well. So we can see across a broad spectrum of these cytokines is that they're elevated over a 1 to 3 year period. So it does suggest that there's this para-inflammation that's going on within the central nervous system, given this is cerebrospinal fluid. Does that make sense? Quite alarming, isn't it? This is just another graph looking at toxins and autoimmunity and the release of antigens, and what happens, you get production of antibodies, your B cells and your T cells, and then of course too much immunity causes inflammation and toxicity in the body as well, so you get this domino horrible effect. We can also see that you've got your IgM responses are also up, and that can affect your tryptophan levels, which obviously affects your serotonin levels, which affects your mood. Low serotonin is going to affect melatonin levels, which is going to affect your sleep. So you can start to see how it's all starting to, building a picture here now. Michael Mays is a chap in Australia. He's probably one of the leading researchers in chronic fatigue in the world. He's looked at the impact of the digestive system and chronic fatigue. And so you can see we've got gut inflammation at the top, which affects mucosal immunity, weakens the intestinal barrier, so you get leaky gut. We all know about leaky gut. This causes a translocation of bacteria, and then those bacteria get broken down to produce these LPSs called lipopolysaccharides. And those lipopolysaccharides, which are a breakdown of the bacteria, encourage or mediate the release of these cytokines. Those cytokines then travel to the brain, cause neuroinflammation, and then you've got your chronic fatigue picture. So that's the relationship between the gut and the brain. So whatever's going on in the gut is going to affect the brain. And there's little bits of research now looking at the impact of the vagus nerve, which is cranial nerve 12, which obviously innervates it's coming from the hindbrain down into the gut, and viruses residing in the vagus nerve and affecting the nervous system that way. So that's pretty advanced stuff that we're seeing coming through. This is just another example of, these are all various symptoms that's on your next slide, but pretty much if you've got low secretory IgA, the impacts that can have on your tumour necrosis factor, and then these inflammatory responses going through. It's just your abbreviations there on your FFs, so fatigue, concentration, irritability, sadness. See, that neuroinflammation is a good way to explain it is that, when you get the flu and you just don't feel right, that's because of the cytokines in your brain in response to the virus that's come into the body. And that's how a chronic fatigue patient feels every single day, is that they feel like they've got the flu. Because it used to be called yuppie flu in the UK, do you remember that, Karen? And it was like only ever affected the middle class to wealthy people, and so they would call it yuppie as in snob flu, and it was all in their mind, but of course it wasn't, it's not. It's likely possibly that these people can afford holidays overseas and they've picked up a tropical disease, and it's the immune component of it perhaps, but it affects all demographics, chronic fatigue. Nobody is left. It's low socioeconomic, middle class, upper class, it affects all demographics.
Do you find type A people get it more?
Type A people can get it more, and there's a possible theory behind that, is that type A personality are perfectionists, they're like dogs with bones. I'm one of those people, and so you just got to really manage what your barometer is for your stress responses, because you tend to take on a lot and want to do everything. And what happens is that when you get into high stress response, is that you shed more beneficial bacteria in your feces. And what can happen is that you can then free up receptor sites in your bowel to take up residence. So those potentially pathogenic bacteria that normally live in harmony in there take up further residence, and they over-colonize, and so you get that ratio is wrong, and then that affects your immunity and your toll receptors that are in your gut, and definitely, yeah. And they're high output, so they're high HPA axis people anyway. And given that the HPA, the hypothalamus, is very responsive to cortisol, it's definitely but it's not. It's speculation. There's not anything that would be adequate enough to say that type A people are more likely to get chronic fatigue. It can actually just affect everybody and anybody. Because these here are glucocorticoids, okay? You've got glucocorticoid receptors in your brain for cortisol to, be taken up and etc. And what we can see with people with neuroinflammation is that we know about insulin resistance. These people are glucocorticoid receptor resistant. So it's about managing, so now we're starting to get more information coming through here as well, is that it's about managing that glucocorticoid resistance that we're seeing going on in the brain, and there's lots of herbs and nutrients we can give for that, so we've got real benefit in what we do. So looking at the HPA axis, I think I'll just briefly go through this because I do discuss a lot of the slides as I go through, so I won't talk verbatim about all of these slides, but we've got decreased basal cortical output. This is this cortisol awakening response. It's better to do it as a saliva test rather than a blood test. It's better to do it over a 24-hour period as well, because you can start to see the peaks and troughs. Like you've got your highest cortisol output between 6 and 8 in the morning. Whatever time you get up, really, that's its highest peak. So it's mobilising sugars and everything to get you moving and going. Then you've got another peak about 11 o'clock, so it's going down like this. And then you've got another peak about 4 o'clock, and then you get another little peak about 7 o'clock at night. And in a chronic fatigue or fibromyalgia patient, it's almost like upside down. Especially fibromyalgia, they're awake most of the night and not able to switch that off.
So you do a saliva over a blood and a urine?
Yes. Yeah. So this is Michael Mays again, the Australian scientist I was telling you about. This is just another example of bacteria, viral translocation, and feeding into this whole cascade effect of what is affecting the brain. Now, who knows glutathione? Anybody heard of glutathione? So glutathione is the most powerful endogenous antioxidant that your body produces. And there's issues with glutathione production in people with chronic fatigue and fibromyalgia. So that's one of the key things that we want to get working. And I'm going to give you 5 key tips that you can take away that you can incorporate into your patients' foods. Pardon?
I'll put that to you.
Is that kombucha? No, that's a probiotic. Prebiotic. It doesn't. No, there's no studies on kombucha elevating glutathione. It's all hearsay. It's a wonderful food, though. It's a wonderful food.
We make it.
You make it? I make it too. I make 30 litres at a time. But I haven't read anything on elevating glutathione levels.
We do it already for 20 years. Drink 3 glasses a day.
Yeah, but you can drink it, but does it actually produce glutathione in the body, though?
Well, I don't know.
I don't know either. I haven't read anything on it.
I feel good at it.
I'm
never sick, so.
Yeah, I thought. Well, I'll come to that. Glutathione is produced in every single cell in the body. It was once thought it was only produced in the liver through phase 1 and phase 2, but it's actually, you've got these little, I can get really technical here, and I'll get technical and you can tell me to just reverse back. But you've got these little proteins that live on every single cell membrane, right? And they're called couch-like proteins. So here's your cell membrane, not really much more. And they're called keeper proteins, which are couch-like associated proteins. And then in the cell, in the cytoplasm, you've got these transcripting factors called NRF2 or ARE. And I'm sorry, I can't remember what they stand for. They're very important in the cell. And what they do is that these guys are like little surveillance cameras. Anything that's going to be seen as an assault on the cell activates these guys, and these guys then activate the glutathione pathway, which is 1 and 2, which happens in the liver. So there's certain foods that you can give that activate NRF2 or ARE, they're used interchangeably, and those foods are cocoa powder, ginger, garlic, rosemary, ginkgo, turmeric. So you can get food, you can start incorporating these foods into people's diets to try and switch on this NRF2 and glutathione. If you get glutathione working correctly, you're going to help with mitochondrial function because you're reducing that toxic load and clearance load in the body.
We're going to investigate it because I'm sure that the meeting workshop is that what that was.
Yeah, I haven't read research on kombucha and glutathione. I mean, we do a lot of fermented foods at home because it's good for your gut and good for immunity. But kombucha is also really high in sugar.
That's what we should have eaten that.
Well, it depends on what you look at. It's still got sugar in it. It can still elevate your blood glucose levels.
Yeah,
Yes.
like 3 grams per 200 mils or something compared to
So where did you get that from?
the cost of a bottle.
The back of a bottle. Yeah, I guess what I'm saying is like, can't always take things as face values because you can look at other bits of literature. And I'm a massive kombucha fermented food freak, and some kombucha can actually just blow your socks off. It can be so powerful. It's amazing. But I just don't think there's enough. We know that it's good for us, but I think there's a lot of people going, well, actually, it does this, it does this, it does this. But actually, we don't know what it does.
It's also never the same.
No.
Every batch is
Every
different.
batch, because the SCOBY is different
I know.
each time, isn't
Yes.
it? And
Yeah.
you know, and it's the energy of the SCOBY, and yeah, but I'd be interested to see. Maybe it does switch on NRF2, because that's how it would probably work. Because you've got massive NRF2 levels in your liver, but you've also got them in every single cell in the body. So that's one thing you want to look at for your daughter, is driving those NRF2 pathways through those foods. So, neuroinflammation and chronic fatigue. So PET scans show these red areas here are inflammation of the brain through a PET scan. So that's quite significant. And the inflammation correlates with the symptom severity. So we've got it's sympathetic dominance. So one of the herbs that we would look at for sympathetic dominance would be hawthorn. Hawthorn's wonderful for sympathetic dominance. And if you think about it, young girls as well often have that orthostatic hypertension that I talked about. Hawthorn would be a really good one to give for that as well, to help that atropic heart function too. So you start to
say, sorry?
Hawthorn.
Hawthorn.
Yeah. Crataegus would be great to give. And you know, it's coming into harvesting time now with berries. You can make elixirs and stuff like that too. And try and get it in through people's food, because giving supplements, like sometimes you just want to give a front end loader with what you think this person needs, but it's just not affordable. The liver has to process it. So the more you can get in through food, the better. And that's one of your hardest challenges as a clinician, is changing people's dietary habits, because they're so hardwired to eat what they eat. And
So you can just eat it non-limited quantities, can you?
well, you can make it up as an elixir. Is probably a good way to have it, and then because you make it up as an elixir for about a month, and then you can you just probably give about 10 mils a day. Just like if you look at the energetics, the body's just, it's got a frequency about it, and so what works for one person is going to be different for the other person over here, and you just get a feel for it when you're in practice for a while. You start to go, well, I don't think that would work for that person. They're very sensitive, and so like hawthorn in a liquid extract might be too nasty or too strong for them, and so giving it to them in like a syrup elixir might be quite nice. Or you could make another good thing to do with hawthorn berries would be to make an apple cider, make a vinegar out of it, and you can give them that every morning. It's fermented, it's going to help their digestion. It's giving them the hawthorn, the antioxidants. It's helping with that whole HPA axis and that sympathetic dominance that you see. So start to try and think about how can I overlap my therapies. I'm never going to fix everything in one consult. After over 10 years of being in clinical practice, I think I've finally got that. You can't fix everything in one consult. You want to, but it's just not possible, of course. And then you come out, it's not really interesting, then you come out thinking that you're a failure as a clinician because you haven't fixed them in that one consult. And then you'll speak to a friend or colleague and they'll go, but they've been like that for 30 years. I know, but you just put that pressure on yourself to do it. But overlapping therapy is one of the best things you can do. So we're focusing on the autonomic nervous system, and then this is a neuroimaging that was done, and we've got the white matter lesions that you would see in Alzheimer's disease. Quite a similar picture here with a long-standing person here with chronic fatigue. So You've got that white matter build-up there as well. And we know that Alzheimer's disease, we know this now, research has just come out in the last year, several publications, that it's all, Alzheimer's disease is strongly linked to neuroinflammation and glutathione and decreasing glutathione production. So, getting those antioxidant foods into people, and organic where you can, like getting a cooperative going, living like a community like we used to. Sounds very much like Little House on the Prairie, but that's actually how we're supposed to live.
Can you just say that again, what it's strongly linked to?
Neuroinflammation and Alzheimer's disease and multiple sclerosis, all linked to neuroinflammation, yeah. So we've talked about POTS, commonly affects young, teenage, slim girls with chronic fatigue syndrome, and often sent to psychologists because it's all in their mind, but they often need to see a cardiologist. Cardiologists still really don't believe in the phenomena of POTS, but it's there. Your blood pressure is supposed to be between 70 and 90. And 110 and 30, and one of my vaccine girls has had a blood pressure of 74 over 46, and fainting 20 times a day. Yeah, terrible. And she actually knocked her head out on a table and lost 3 years of her life just with the concussion. So her little brother was a bit like my children, really massive age gap, but her little brother was 3 when she knocked her head, and he was 6 when so she remembers him as being 3 because she didn't remember the last 3 years of her life. So, it's just, this is a terrible condition, POTS. It's not a phenomenon, it's real. One of the key things to get going with these girls is, because it's always girls mainly, is increase their fluid and salt intake. So get them having good Himalayan salts in their diet, regular sleep and meal schedules, of course, because often they're sleeping past meals as well and they're not hydrating well enough. And this particular girl with the hot summer that we had in Christchurch, her fainting episodes were becoming more and more and more, and it was just pure dehydration essentially. You've got to keep those levels of fluid up.
You said 74, 40.
47, 74 under 47. This one. This is it. That was her blood pressure. Yeah.
Incredible.
It's a wonder she was breathing. Yeah, she was really grey and pallor. This is the girl in crutches. But yeah, so the key thing is just getting good fluid and salt and regular meals and sleep. And IV vitamin C seems to be working well for this girl as well. So we've got increased oxidative and nitrostatic stress. So one study shows severe oxidative stress after exercise. So the glutathione levels is one of the key things to get up and going. Their vital heat shock proteins responses are down. Heat shock proteins manage the cell, if you like, apoptosis and things like that. And these are heat shock protein 27 and 70 there. So mitochondria, we can see that we've got control, fibromyalgia and chronic fatigue. I'll just focus on chronic fatigue here. So they've got much low levels of CoQ10, which is involved in respiration in the cell. They've got high levels of lipid peroxidation, so that's going to cause oxidative stress. And they've got really low ATP levels, so the Krebs cycle isn't working as well as it should either. So that's that mitochondrial function that we focus on. This is looking at multiple sclerosis, Parkinson's disease, major depressive disorder, chronic fatigue syndrome, systemic lupus, psoriasis, rheumatoid arthritis, and looking at the whole impact of those conditions and how it feeds into a metabolic dysfunction of the brain and secondary fatigue. So you can start to see common pathways coming through with these brain disorders. So heart function, it looks like these guys are in heart failure some of the time, not all the time, decreased stroke volume and cardiac output, and again, back to addressing the mosaic concept and looking at those 3 Ps, but we've got an additional P So we've got predisposing, precipitating, perpetuating, and then we've got the pathophysiological basis as well. So that's looking at the emotional component in there too. So CBT can be, cognitive behavioural therapy can be beneficial for some of these patients, but not all. And I think it really comes down to a social structure that they have. And we're going to talk about schizophrenia, any kind of mood disorder. It's all about, the recovery is about the social structure that they have. So genetics, constitutional, allergies, autoimmune, viruses, these are all predisposing and precipitating factors. Do we need to stretch?
Yeah.
Yeah, we've done an hour and 15, so it's probably long enough. Hour is good for adults. We do, we learn better in hour chunks, so. All right. See, that's what I mean. We all talk our own truth. So do you want to come back in? It's 2:45. 3:05. Actually, make it 3:05. We've still got a lot to cover.
Have you seen a patient with reproduction system? Have you seen a patient with a reproduction system? Like I know
There's a hormonal component, which is why I think girls are more impacted than men. But the whole neuroendocrine system is out of balance because of the HPA axis, so it's going to have an impact on hormones.
because I see a patient a week before period, the fatigue is bedridden, and then the period comes, and then she starts looking at me.
Yeah, well, ordinarily women would feel more fatigued before their period anyway, because they're stored in iron and preparation for losing it through menstruation. So everything is just more exacerbated, I think, with chronic fatigue. Patient, how long should you live for?
She's diagnosed at 15, so she's 14. I don't know. The endo seems to be a big picture, but you see everybody lumps it.
Or treats it as separate things.
Yeah. But the endo seems to be.
Are you from the capital area?
Yeah.
Do you see Trinity Subu? She's a integrated doctor. No. That's good. The other person is Alicia Melrose from Wellington. Alicia Melrose. She's going to be retiring soon, so if you want to see you, get in.
Yay! I don't have to make any
She works
changes.
from her home up in just in the north of Wellington and Belmont.
Well, we've taken to spend thousands as we don't know who got. Yeah. You sort of get sick of trying, I suppose, and spending money.
I think the key thing is getting that information down on the brain.
Not entirely clean.
Yeah.
I find it fascinating.
But if you use hers McSorely and turmeric, it has the blood-brain barrier.
I do like all the medical stuff.
McSorely and turmeric, like in high doses, because they cause the blood-brain barrier. They'll downregulate the cytokines.
So we're not allowed to use herbal extracts here.
Because you're doing naturopathy, you're not doing.
Yeah.
Alright.
With chronic fatigue.
Are you going to do the herbal papers?
I'm going to go to
I was nervous, so the first stuff I did, I realised anything, so.
No, but that seems just trying to get people.
It's so useful before.
You want to just
Yeah, well, I want to, yeah. She's the one that's trying to be medical stuff.
Who is? Her wife.
Yeah. Because that's what I'm like, if I carry on doing this, pay me the right amount of money for the certificate.
I would like to try.
First person, I'm topical. Otherwise you're going to go.
cultures. She's learning.
She emailed me, yeah.
Yeah, and also do Katie Bones. Katie Bones, like, has made he's one of his was part.
He doesn't do that.
Yeah, he's got a certificate in herbal medicine. And I tell you, it was straight shoes, very challenging. And it's very nice, so easy to manage. Pardon? 150 an hour. Yeah, you can do a certificate in herbal medicine through them.
But actually,
Yes.
and then I can do it.
Then once you've done his course, you go to it's very challenging. It's amazing. Get through this first.
Yeah, I know when it's going.
I saw this busy enough.
I thought it was right. You haven't looked at it, it's not very good. No, that's okay. Yeah, as long as you've got that process. Yeah,
Filming it.
I think so. We should have stopped it, shouldn't we?
Has it stopped?
I don't think we did it up tonight. I don't know, I didn't place my I don't know if they placed it when they first came in. 1 hour 42. Yeah, no, it's recording. I wonder if I press stop. No.
You might stuff it up.
Maybe I shouldn't. Don't know. You have to listen to me all the time. It's just joining dots. It's just you're constantly joining dots, no matter how long you're using it for.
But it's nice to know what's all happening in your body, you know, instead of, oh, we have to do that, that's why they ask all the time.
Always answer.
And you're quite right, you can't fix people. People fix themselves, you know, and you just point to it. And it's very hard to change people's minds. That's why I love Tom Torrance so much when he starts talking. And, I mean, he knows these things as well, but he then says it in a way that people can understand it. People understand it. And I think he has a lot of success with changing people's habits, the way he presents himself. Tom Tolman, he's an American. He travels all over the world. He's in his 70s. The last 50 years, he's been traveling all over the world to talk about people that they have to change their diet to whole food. So I've got a workshop with him. He's a wonderful man. It's just amazing. And that's the thing I would like to do. Yeah, something like that. I mean, really, what my wife and I would like to do is set up a retreat. And people can come for a week or 2 or 3 weeks and have the healthy food and the healthy lifestyle. Just take them out every day for books and give massages. That's really what we like to do. Half a year and half a retreat.
Yeah, absolutely.
Yes. No, we were living in Christchurch, we had a house in Christchurch. And I came specifically, or we came here, to be near year of college to start my studies. So we're just renting for the moment because I have a feeling that either going to go towards the model residence or leaving my college to have a retreat. So anywhere where we can have walks on the beach and walks on the bush. Yes. So that's why I walk back home. Spring tea in raw sugar, and we've got 100 strawberries from all of the time now because we make a little noodles and so my wife is kombucha workshops. Did it? We keep it in big, some glass containers, some of them, I think about 3 or 2 in one big container. Living in harmony. Yeah, living in harmony. No, it's a nice drink that you buy. It is alcohol. And it all depends how much it converted the level of sugar you take in. In some batches you can feel it tastes sweet, in other batches it's just like on the vinegary side. And sometimes it works, you know, sometimes it works. Oh yes, yeah, my wife puts in sometimes different things in as well, like berries, always different things to try it out. No, I mean, we rent here, so we don't have background and our deck is full of herbs, 40 or 50 different herbs that we grow all the time. And then we make tinctures out of it and salts. Yeah, I'll enjoy myself. Time and well, yeah, in the future maybe. Yes, but my idea is more to have a retreat and then people coming and over the 2 weeks time you can have a feel for the people, teach them and at the same time give them advice in what kind of herbs would be good for them. And like I said, everybody is unique. The only way to find out about it is to know their history and to see how they live. You know, to see what they say, because it's all their thoughts, their speech, and from that come their emotions and their habits, and try to change things. Yes. Well, the first place you have to know yourself and you have to know what are my reactions to whatever comes to me. If a dog comes to me and barks, what's my reaction? And then if you know your reaction, you can change it all the time. It took me 6 decades to, and I'm still good. Yes, but it's lovely. I just can't see any other future than healing. You know, with your hands as well. There's all the vital energy that comes through. There's a lot of exercises that you can do that you can get in the walking way. It's lovely, isn't it? What we do when people come to us, like friends or whatever, is because my wife and I every morning we meditate separately, and then we have yoga, like 3/4 of an hour by an hour yoga. Of course, you can only do this if you don't have to go to work. That too, you know, that I couldn't do it when I was 30, but now I can. And so when people come to us for a week, like in Belgium or where I was born, then we asked them, would you like to live with us? Or we can do what we do. And some do, and others 50 minutes younger and they're tired. But it's fine. At least they have a little taste of it. Exactly. And it's so lovely to do to be in service and to give people that incentive to do something for themselves. But they have to do their own research.
Yes. Yeah, so I mean, I came up there, but don't get me wrong, I'm not going to work for a year. I think it's working candidate. Do working casually, yeah, like for work. So we can travel for 2 months, and you know. Yeah. Oh, exactly. Travel all the way up to the Kimberleys, and it's just been unreal. But financially,
you're enjoying it, that's it.
Oh, yes.
so right now, I'm really excited about it.
Why do you choose to use it? So you choose to use it not to talk about it.
Exactly. It's a solid foundation. Yeah, well, my thought, you know, I often do things sometimes that are excited about for like a 2-week period, and then next week into what I really want to do for the next year.
I live life
For example, you know, I made coffee socially for 2 years, and it's so it's also nice to like the
team and wine course.
that we were part of the same country, so that was scoping, not work for 2 years.
Needs must, don't you? You've got to look at the pros and cons of what you're going to get out of it.
Does traffic get busy here? I just wonder how long it would take to get to the airport.
No, that's actually great. Yes, like all of us will say, you
Wouldn't take me half an hour.
I don't know, just
Yeah, we might just get a cab for 25 to 5.
Just cheap for them. Yeah. Oh, really?
Yeah.
Really? I'm happy being a mess.
Where are you from?
At this moment.
Could be a much like that if it's just throw a little bit back on
Yeah,
it.
that's fine. You know, she's a. I don't even know. That's the other thing.
She's only just coming like that.
I really want to work with her. It's an amazing one. It's out there. It's really fixated on cancer, like predominantly. I think it's really a 3-month program.
I've got like nutrition Have you heard people like Patrick Holden have a
I know. Councillor that worked on it.
but she used to run a county a lot of council. Just amazing that whole. Even natural confidence. It's kind of that where it's just and even on one level that you know it's huge detoxification of the body, it's just such a task, isn't it? You know, it's just like
And now it's so it doesn't have to cancer, a lot of that they keep so good, the foundations are good at these symptoms, they just become
All right, we'll get started because we've only got an hour and 25. So.
Portugal and someone.
Sorry, we'll Any questions? It's a lot of information. So any questions?
To be honest, it's all a little bit advanced, at least for me.
Oh,
It's,
cool, me too.
To be honest, yeah, I feel like I actually, like I've missed a module or something, like I've missed an assignment
right.
going, oh, I feel like this should make more sense.
Yeah.
But, so a lot of it's, some of it's ringing bells and then a lot of it's really new for me.
Yeah.
So it's getting a bit of a brain,
So
when
I
you mentioned
guess-
a brain
I guess-
fog, right now.
Okay, that's
Oh,
good.
so
That's good. So we can
HCFS, right, okay.
we can touch on parts that you're not recognising with, and maybe I could do like a 101 with that for you.
Well, it's
Before we
fascinating
move on,
stuff.
yes.
It's just that all of it.
Yes.
If I was
All of
to
it.
go over each thing that doesn't quite make sense,
Right.
you'd be my private tutor, which
Right.
would be great.
Okay, right, okay.
Do you think maybe that it's okay that we don't get it necessarily, because most of the people that will come to us will either A, know that they've got chronic fatigue, or B, have symptoms that you would recognise, that then you can just go on and break up that mosaic and treat those bits. And
Yeah. So that's the thing, like,
Okay.
it's just like taking key concepts, like if you've got, like this stuff is technical, and so when you get a patient, that's actually how you learn, is you learn by your patients, because you have to go and you have to go and read it. And that's how I've had to learn it. And with the key concepts that you'll take from today is that you'll remember that there's a massive brain inflammatory response with chronic fatigue or fibromyalgia. So that's one of the key things that you're going to take away with you today. And then from that, you're looking at, well, what am I going to do? How am I going to treat that? And so then you're going to look at those 4 quadrants. And so we're going to be looking at immunity. And so then you can refer back to your notes on immunity. Then we're going to look at mitochondrial function. Then you're going to look at the inflammation in the neural endocrine function of it. So that's that whole HPA axis. So it just, I guess one thing that stood out to me is that when I was talking about the HPA axis, some of you weren't following me on what that was, and I thought,
who's done the stress?
So you
halfway through.
Yes.
so you didn't do that in year 1, you didn't do the
No, I
HPA
didn't.
Do it
axis.
towards the end
It's
of your last year.
Oh, I see, right.
Most of them never done that.
Oh,
When
I
you're
see.
already adrenaline stressed yourself, wasn't it?
Yeah, absolutely, that's right.
Okay, study.
Oh, is that good?
Is it alright? I just take a bit of a thing.
What do I do?
The taxis are really expensive, so I've got you a shuttle.
Oh no, I need to get a taxi.
Oh,
Yeah,
okay.
yeah.
Okay.
Yeah.
Alright.
Yeah. So that a taxi.
Did you say what time?
4:30? I'm going to 4:30. I need to be at the airport at 5.
At 5, yes.
Okay, thanks. Sorry. I cannot miss my flight because I'm going to Dunedin tomorrow morning to present, so I have to leave. So yeah, so it's just, I guess I made the assumption that you learn A&P and pathophysiology in year 1, but you haven't necessarily learned that in year 1.
Well, some of it we have gotten all the way through, but it's
Yeah.
so long ago, we haven't
Yeah.
really applied it in that much detail.
Yeah, right.
So we learned about the Krebs cycle and it's ringing bells, but not enough that I can go, oh yeah, that's yeah.
Well, you wouldn't be expected to learn the 10 steps of the Krebs cycle or recall them, but you could leave today knowing that there's mitochondrial problems, and so, you know, if you can grasp the key concepts that come out of, say, these seminars, then you can always refer back and read. Because a lot of this is technical, but this is actually what's going on in the body with this condition, and you're not expected to learn that it's all these different cytokines, which is your T-cell mediated response, but you now know from today that it's a T-cell mediated response that is in the brain that shouldn't be there. So, you know, just if you can, so maybe it might be better if we just did an open forum about some stuff, and then you have the key concept of what chronic fatigue is, knowing that fibromyalgia is the next part, but we don't need to cover that. We can cover fibro. You can assume that what's going on with chronic fatigue is also crossing over with fibromyalgia. They're very similar conditions except for that HPA axis, but it's still dysregulated. Fibromyalgia is upregulated. So you're going to think about steps that, so I think that's probably more beneficial for us to do that actually, rather than me talking more about stuff that's vague or stressing you out more, because that's not, that's
really stupid right now.
No, don't feel stupid, because no, that's not a good way to feel. So try and downregulate that. But the key things with chronic fatigue is that it's a low HPA axis.
So low, it means that it's not functioning.
Yeah, so it's kind of shut itself down in a way, yeah, and so it's become dysregulated in what messages it sends to the rest of the nervous system. Alright, so you want to kind of get it back filtering as it should, essentially, and that's why these people are so tired.
So therefore their stress responses, they're not quite as stressed out then, are they? Because is it?
Yeah, if you see a chronic fatigue patient, my experience is that you can sit in a chair with you in your clinic and they come across that they just really don't care, they're quite apathetic, and they just
There's no will to live, basically.
But yeah, it's because they just are so fatigued, absolutely exhausted. And you'll also get the difference as well, and it's in your notes and you can go back to it, and I think it's probably better that we don't go through any more of the slide, we can just talk to what we've already talked to, is that with a fibromyalgic patient, is that they've still got that neuroinflammation that I talked about, but they are, they get like the restless leg syndrome, and so I've consulted with somebody actually standing up because the pressure on the backs of her legs on the chair is just way too painful. So they've got a different kind of presentation.
More stress.
They are high HPA, so they've got excessive cortisol reduction, and they've got really high pain. So they've got major, like they've got various parts of the body where you can't even put very light pressure on them, and that's one of the differentiating factors of a chronic fatigue and a fibromyalgic patient as
It's
well.
in the words itself, the fibers of the muscles.
Yeah.
That's painful.
Yeah, and you'll see in your papers there that they talk about the peripheral nervous system and how that's impacted more than a chronic fatigue. So there's quite a difference. One of the key things is that whole HPA axis. It's high in fibromyalgia and it's low in chronic fatigue. Yeah, so it's high in fibromyalgia and low in chronic fatigue.
So
ultimately it's completely dysregulated no matter which condition you're looking at.
So if the fibromyalgia person is secreting lots of cortisol, will they eventually end up with fatigue?
Yes.
And then they won't.
But it's a spectrum, you see, so then we can go, well, that's black and that's white. But it's still a spectrum, so somebody from chronic fatigue can move into a fibromyalgic picture and then move back into their dominant chronic fatigue state. It's like autism's a spectrum, depression's a spectrum, anxiety's a spectrum. Depending on what, using that 1 metre jag analogy again, depending on what's going on in that 1 metre jag, they can sway within that. But you're right to assume that a fibromyalgic patient, you definitely have to give them, because my training is in herbal medicine, but you definitely have to give them like adaptogens. And so as naturopaths, the equivalent for you would be, for me, I would be giving Withania, which shuts things down, so ashwagandha. I'd be looking at giving things like Romania and licorice, which are good adaptogens, but they're also restoratives because they can move into that adrenal fatigue picture. And so an equivalent that you'd look at, naturopathy, is vitamin C, magnesium, fish oils, which are significant. So why don't I just be loose and just let it see where it goes? Do you want just to do that? Okay. So with fish oils, like fish oils would be one of your primary things that you would use naturopathically for chronic fatigue or fibromyalgia.
So for both.
Yes, because we're talking about neuroinflammation now. So both of these are neuroinflammatory responses, all right? So we've got
What type of fish oils are you on about there, like your Nordic naturals or your fermented ones?
Goldfish.
So you could use Nordic Naturals, or you could use, there's another amazing one that's completely mercury free, which is bioactive lipids. So most fish oils have got an allowable component of mercury that they're allowed to have that's safe for human consumption. And Nordic Naturals is one of them. It's one of the premium fish oils on the market. So I stock that in my clinic, but I also stock bioactive lipids, which is 100% mercury free. It's had it all extracted. So you'd be certainly looking at giving a mercury free to all of your patients, but especially these chronic fatigue and fibromyalgic patients who have got massive issues with detoxification pathways.
Has it still got vitamin, the naturals vitamin A and D? Because a lot of fish oils are...
Depending on the source of fish. So if it's cod liver oil, yeah, they'll have A and D in there. But some of it's anchovy, some of it's sardines, so it's depending on the source of. But sardines and anchovies have still got your D and your A in there as well.
Green lip mussels.
Yep, green lipped mussel. But if you look at fish oils, we know that what's the primary component of a fish oil? What else? So DHA and EPA, right? But DHA, we're going to focus on DHA because it's D for depression, that's how I always remember it. E for inflammation. So that's a good way to remember it. That's how I remembered it in college. It's still stuck with me. So if we look at DHA, I'm going to make you very bright naturopaths today, is that DHA, we think, oh yes, that's a COX inhibitor and a LOX inhibitor. So that's your cytokine inhibitors, right? Those are enzymes that inhibit inflammation. And that's directly what DHA does, right? So it decreases COX and LOX. That's how it works. But what we also know now, in reference to what we've looked at today, is that these chaps also produce what they call neuroprotectins. These are metabolites of DHEA, so if that's how you want to write them. Okay, so that's neuro, anything to do with the nervous system is neuroprotectin. And they're metabolites of DHA because they're neuroprotective. So this is how, in answer to your question, Karen, like using fish oils, this is why you would use fish oils in chronic fatigue or fibromyalgia or schizophrenia, I'm just going to go for it now, or autism, or depression, just the raft of psychiatric problems that you can see with mood disorders, right? So you've got DHA. The metabolite of DHA is neuroprotectant, and it's also called maresins. Now, one of the key ones that's had a lot of research done on it is called resolvins. Now, these resolvins, this is cutting edge stuff, so you can go home and sound really clever tonight. Resolvins, there's about 6 of them that are produced, and they're called RAs, V1, RAs, V2, through to 6. And what these guys do is that they take a step further than this, and they go down the pathway of, they decrease those cytokines. So they're not just working on an enzyme level, they actually stop the production of cytokines from your mast cells. So that's from B into T cells. So that's actually how they're working. These, your liver produces these as well.
But it also comes from the DHA.
But it also comes through the DHA. So if you've got a vegetarian, no, don't eat fish, that's all right. Well, how are you going to get omega-3 into them then, so you can get DHA into them? Fish. But they don't eat fish.
Hemp seed.
No,
Flaxseed.
fish oil, flaxseed.
Hemp seed?
Put it into them.
Hemp seed, flaxseed, what else?
Um,
Yeah. So So
What
how
did
do you
you
get
say?
how do you
Chia.
yeah, how do you get that into the diet then?
Sprinkle it on the sides.
Yes, the key thing is you have to give them ideas. This is new stuff to them. How are you going to get it into your food? How do you, so ask them what would be a good way for you to get this into your diet. You might give them some examples. Because they've never heard of it.
Soak the seeds and put them in a smoothie.
Yeah, it's one of the easiest ways you'll get this stuff into your children and your patients is smoothies. Yeah. And so the other key thing that we talked about was we want to increase glutathione pathways with these people. And so how can we increase glutathione through smoothies? If we looked at that whole NRF2 that I talked about in foods that switch that on, what foods could you put in your smoothie? Yeah, cocoa powder, grated orange rind. So these are little things that you need to start archiving so you can give them out as recipes to your patients. Yeah.
What they call them? Glutathiones. Yeah.
Glutathione, so yeah. I'll spell. So we'll use this board. So we're gonna get DHAs into them. We're gonna get NRF2 herbs. You guys need to know this about NRF2 because doctors aren't going to know it. They're not going to know how to switch this pathway on. So NRF2 also know. If you go in and Google this stuff, you'll get information on it. Do you know about Google Scholar? Yeah, that's great. So so we want to use NRF2 ARE herbs. So that's you go the 3 Gs. So that's ginger, ginkgo, green tea. You can put garlic in a smoothie, but they might not like it. You can put it in their stir fry. Gotu-kola is good. Yeah, you could use how that works. You could use gotu-kola. It's quite difficult to come across that in a food though. I'm just thinking about. I might just keep it to foods rather than. Because you could do a really strong brew of tea and let it cool down and put that in the smoothie, or just have it as a tea. The other thing you can use is cocoa powder. What else? Turmeric. Kombucha.
Sorry,
That's alright.
So those are the. So when you say NRF2, that this is what's.
This is to increase glutathione because these people have got significant issues with their glutathione pathways. Yeah. I love to teach you because I love to teach you all this stuff. I think it's so important. This is good. The other thing is you can use like citrus rind. I've got a really nice recipe that I give my patients which is called a Jaffa smoothie. So they've got citrus rind, the juice of an orange, cocoa powder, put an avocado in it to get the essential fatty acids, chia seeds, coconut milk. I use sesame flour, and you can put all sorts of things in there, but just to try and switch on this NRF2 because the body is so innately intelligent that it has the capacity to detoxify itself. The body always wants to maintain equilibrium, and if you give it the right environment, it's like Pasteur and Louis, isn't it? It wasn't about the environment all along, and Pasteur said it was all about the environment, and Louis was going, no, it's about the antibiotic. If you set up the right environment for people to heal, the body's always trying to heal itself, always. You can see that with every single thing, everything.
What were those smoothie ingredients again?
So it's just cocoa powder. You can use the citrus rind of an orange and the juice. I use an avocado. You can put a banana in there as well, depending on, like for some people with chronic fatigue, they have anorexia, so they've got very poor appetite. Not anorexia nervosa, just anorexia. So you've got to encourage them to eat and not to skip meals, especially if they've got that orthostatic hypotension that we talked about. So for many, like breakfast is difficult because they don't have that appetite. So you can try and get it into them with a smoothie. And I mean, this is live food. And if you give people live food, they're going to feel alive. You can't not. You know, it's. So this is in your book. There's slight variations on the 5 food policy, but this is just a little bit more extended.
In which book? In our
In your manuals, yeah.
So with the turmeric, does it need to be like with an oil and black pepper to get the benefits of it?
Well, if you're giving turmeric with avocado, which has got fat in it, it supports bile production, and so curcumin is better absorbed when there's bile available.
What about the whole black pepper thing? Is that just a myth?
I don't know. You're coming up with myths. I like them though. Yeah, I don't know. I don't know about black pepper and turmeric. I don't know about that.
Alright. I think the black pepper might be to help stimulate the bile production to dissolve the turmeric.
But black pepper is used a lot in Ayurveda because it's a warming spice, and so. But if you might be, it sounds like you're referring to 2 different things. You're talking about fat with turmeric and black pepper with turmeric, and I think.
I thought they needed both of them to get the maximum out of the turmeric.
No, curcumin needs a phospholipid, so it needs a fat component for it to be more bioavailable. And so you can get bioavailable forms of turmeric, or you take it with fat in your diet, which is an avocado. Yeah.
I was just going to say about that.
But black pepper in it would be nice too, though, as a warming.
I was just going to ask about the golden tea, which is new turmeric tea, which you can do with ginger, and like what Maureen's saying.
Yeah.
From the research I've done, yes, you need the fat with the turmeric, but from what I understand with turmeric, there's only 3% of curcumin available for absorption, and only 1% of that gets absorbed. You need some fat source for it to be absorbed. And the black pepper, by utilising black pepper, it actually increases the absorption rate by up to 2,000% from what I read.
I haven't read that on black pepper and turmeric.
I've read it in quite a few places.
Yeah, no, I only know about the phospholipid component.
I think it has to be both from what I understood.
Yeah, no, I haven't read anything in that respect.
You can put a wee shake of black pepper in your smoothie.
You know, black pepper's warming, it helps digestion, so maybe it's around that rather than absorption, because it's actually a stimulant of
It
getting
stimulates the
blood flow.
enzymes.
Yeah, so maybe it's more that rather than actually taking the turmeric across the cell membrane. Yeah, because that does definitely require phospholipids. But I'll have a look at that and have a look at the literature. So where was that published?
I'm not sure, but I've read it in several different sources.
Yeah, well referenced.
Sorry?
Is it well referenced?
It is quite well
Yeah,
referenced.
I'll have a
I
look.
discussed it. I go to an NZAMH group and we discussed it there as well.
Alright, sweet.
So
I'll have a look at that. Yeah.
that's just what I've come across anyway.
Yeah, no, that's good. It's good to raise it because then, yeah, we can all, learn something new. That's good. That's good. The thing about turmeric as well, and boswellia as herbs, is that they're 2 herbs that can actually cross the blood-brain barrier. And so your blood, do you know about the blood-brain barrier? So it's like a cling film, if you like, around the brain that's selective and what it lets in and out. It's got serotonin transport mechanisms, sodium, potassium transport mechanisms, but it's very selective in what it lets through. And especially when you're dealing with this neuroinflammation, you want to be able to cross the blood-brain barrier so it can have that anti-inflammatory activity. And of course, boswellia and turmeric are COX and LOX inhibitors. So you want to be, so we've got DHA, NRF2. The other thing we want to focus on is immunity. So if we look at Candace Pert's work? No, she's written a book called Molecules of Emotion, and she's a neuroscientist, and her husband's an immunologist, and they hypothesised that for every single neurotransmitter that was produced in the brain, that there would be receptor sites on all your immune cells. And they were right. And so in the late 70s, psychoneuroimmunology was born, and is looking at the relationship between your immune system and your central nervous system. So one of the key things, this is what this is about, this immunity. So what was the herb that I discussed earlier?
Echinacea.
Yeah. So echinacea would be, because you guys don't have access to herbs per se, but you've got access to echinacea tea and stuff like that, haven't you? So you can get your patients doing tea. So for example, we want to get rid of the inflammation, which is key, one of the key things of this condition. And so what are anti-inflammatory herbs? You could get them making a tea with echinacea. What else? Turmeric.
Rosemary.
Yeah. Ginger. And because the HPA axis is dysfunctional, one of the things that is good for high HPA axis or low HPA axis is licorice. So you could put licorice in that tea as well, and licorice is also an anti-inflammatory. So without supplements, we can start to see that we can give them tea, we can start to get things in through their food. So the DHAs, we're looking at fish, whether it's from a capsule or sardines or anchovies that you eat, or wild salmon, for example. There's far more DHA in that. We can use chia seeds, flax, or hemp.
What were those fish sources that you just mentioned?
Sardines or anchovies, or wild salmon. It's very difficult to get wild salmon, it's very expensive. So we're going to focus on infection. Now, what's one of the primary minerals that we would focus on for infection? Yeah, so we're going to give some zinc. Anything else?
You said before vitamin C.
Yep, so for mitochondrial function.
Oh, sorry.
Yeah, we're going to, no, that's good because that was my next thing. We're going to give vitamin C, we're going to give magnesium.
Magnesium.
What else would we give for? Yeah, CoQ10, absolutely.
I just always think of makeup when I hear that.
CoQ10.
Yeah, just on adverts you just hear that thrown around.
Oh yeah, and creams and stuff. Yeah. What else would you give for mitochondrial function?
B vitamins.
Yeah. So where would you get B vitamins from? What if they've got candida?
Animal products. Well, whole grains.
Yeah.
Yeah.
So, but we'll put brewer's yeast down, but we'll just be mindful there's always a gut component to these people. So we'll put brewer's yeast. What's one of the key food sources where you get B vitamins from them?
Of course.
Liver. Yeah, liver is a good one. Liver is very high in iron. Vegetables. Vegetables are reaped in Bs, especially your green leafy vegetables, your cruciferous vegetables. So one of the key things I'd be getting into these people is cruciferous vegetables.
Does that mean brassicas and such?
Yeah. And cruciferous vegetables are available all year round. They're seasonal, but they're there all year round, and it's because they're very high in your B vitamins, especially your folate and your B12. There's about 300 different folates in vegetables. If you suspect that somebody's got issues with folate, one of the vegetable that's highest in folate is peas, green peas. It's one for mental health, Karen, folate. Green peas, very, very good for mental health. Okay, so we're looking at food. We've got quite a little repertoire that we're building up here. So we've got vitamin C. You can get that through either juicing or food, just having 2 to 3 pieces of fruit a day, if they can tolerate it, of course. They might not be able to tolerate it, they might be on a FODMAP diet when they come to see you, which means that, you know, fructose doesn't agree with them, so just, you know, you might have to give it to them in a supplement, that's what I'm saying, if they can't tolerate it. Magnesium is your cruciferous vegetables as well, green leafy vegetables, or again, if they're so tired and suspect the Krebs cycle is so depleted, then you're going to have to give them magnesium citrate or magnesium orotate. If you're going to give them CoQ10, you're better to supplement with CoQ10. If you can, you're better to supplement with the active form, which is called ubiquinol. And that's UBIQUONOL. Then we're going to give them B vitamins. So I didn't put quinoa in there. It's a good protein source as well. So you've got quinoa, brewer's yeast, cruciferous vegetables, getting your B vitamins into them to try and drive that mitochondrial function. Often these people are not able to work, so their funds are quite low. So it's better to try and get things through food if you can. You can sometimes, if you've got a good caseworker and you write a nice literature, you can sometimes get some additional funding for them on the sickness benefit to supplement a couple of things that you might need for them.
Like sprouts and microgreens and things like that.
Yeah, definitely. Anything raw food is good. So we'll put sprouts, the likes of you're thinking of your kale and spirulinas and things like that. Is that what you're referring to, Laura?
In sprout form.
Yeah.
Just put it in the sprouts.
Oh no, I'm talking about your microgreens.
Oh, no, like the sprouts, they can be called microgreens.
Oh yeah, right, okay, right, yeah. So any sprouts really, essentially, yeah.
Because sprouting isn't necessary, what I understood was sprouting is just when you sprout the seeds and they have a little tiny bit, and microgreens are little wee seedlings,
Yeah.
and you eat them.
Yeah.
So
Yeah,
my
and
understanding that's
all, like all pre-digested as well, so often they can tolerate them better because food sensitivities are really high amongst this group and they're high because they're Th2 dominant, and Th2 dominant causes atopic conditions and allergies. So again, looking at echinacea to downregulate that dominant Th2 pathway. So we've covered a little bit of the neuroprotection with the DHA and increasing that NRF2 pathway. What's another simple thing people can do? It doesn't cost them anything, requires a little bit of discipline.
Meditation.
Yeah, meditation. Meditation is we think of it as sitting quietly and peaceful and going into ourselves, and that's really important, but meditation can mean all sorts of things for all sorts of people. So meditation, for myself, example, is to walk. I'm not very good at sitting and meditating because I'm a type A personality, and I'm like, alright, are we nearly there yet? Because it doesn't do anything for me. So walking, reading a book is meditative for me, it's time out. So just saying to your patient, what walks your boat? Where is it when you don't have any of that dialogue and that noise that's going on in the mind? What is it? Is it playing the guitar? Is it, whatever it is, that's whatever shuts their mind down from the chaos, to get a sense of self. Like, what is that source for that person?
For some people it's playing computer games, but I wonder if that's
No, it's true. I mean, if you look at our new generation, it is. Even if you look at probably all of us in the room, we're all on, Facebook. People like social media, they see that as a form of relaxation. It's an interesting one, but we're becoming addicted to media, and that's another topic. Looking at what that actually does and what it does to brain development and what it actually does to the blood-brain barrier, because you're just surrounded by this Wi-Fi, which breaches the blood-brain barrier and increases your risk of expressing all of this, actually. I mean, I don't know if I said it to you, but they banned Wi-Fi in kindergartens in France in January 2015 because of its impact on the blood-brain barrier on these children when they're at the pinnacle neurodevelopmental stages of their life.
Why
need Wi-Fi in a kindergarten anyway.
Well, computers and offices and stuff.
Okay. Yeah, all right.
And then kindies for the children to play with.
I mean, it's everywhere. You can't escape it. It's everywhere. But somebody who's really sensitive on this chronic fatigue fibromyalgia spectrum is you make sure that they're not next door to the router and the Wi-Fi unit. That can have a big difference on that insomnia, hyperinsomnia picture by removing Wi-Fi from their sphere as well. Same with any, these really sensitive individuals, schizophrenics, borderline personality, autism. Any of those areas where there's neuroinflammation going on in the brain, you want to remove Wi-Fi or turn it off at night at a minimum. Because it makes the world go round now, doesn't it? We're not functioning without our computers, but so turning it off in the house at night when everybody's resting.
How about smart meters then? Smart meters.
Smart meters.
Yeah.
Yeah, I don't know much about them.
Some places have them installed to send off data to the electric companies on how much you use all the time.
Yeah.
And they're consistently running on Wi-Fi, and there's a huge amount of controversy over them, and some people are saying that they're affecting them a bit like people who are sensitive to Wi-Fi and certain electrical stimulation. So they're meant to be causing significant health risks for some people.
Yeah, definitely.
And there's nothing they can do about them because it's not a choice.
All these things, I see.
You should be able to have that choice. I have heard of some people having problems, but generally you just call the company and say you don't want to.
I've got clients who have smart meters installed and the companies will not remove them.
They can take the chip
When we're
out.
told that they would be removed, it would be $150 to do so.
In Australia, it's complimentary. You can't have them removed. Here you can, but not in Australia anymore.
They can take the chip out, which stops the feeding.
Right.
Change companies.
They
There-
can't
there
in the
is-
situation. There is something that you can put over it though, that's meant to.
Yeah, that's what I was thinking.
Yeah, there is something I read on the internet.
Maybe you could put it in the box and
It's still a Wi-Fi device, so it'll still be admitted.
yeah.
No, they created
Yeah, it's just if you've got something that you can put over it and it still works, you have to question whether that's something you're putting over it is functional.
Yeah. Well,
Do you know what I mean? It's
There's
just
chips that you can get to put in your cell phone. They're like little crystals or stickers or whatever, but they're like $400 but your phone still works.
yeah.
So what is
I've got one of these for my phones because with my job I spend a lot of time on the phone, and so I refuse to have my
That's
phone
pretty cool.
to my ear because
That's rad. Yeah,
it's
I use
just
speaker.
But if I'm on in the airport or whatever and I can't go on speaker, but definitely. But this reduces your radiation by about 95%.
Rad.
So these are good things to refer for your patients.
What about headphones? Is that
Headphones are fine as well. But yeah, I mean, if I'm in the office, I'm just using this all the time, so it's much easier. And it is.
you get that?
I did. I got it on Amazon. I went to a conference, the MIND conference, which is integrative medicine for nutritional medicine and mood disorders, essentially. And it's for autism in children. And Nicole Bilsma is she's a naturopath, and then she went off to train to be a building biologist. This outrageous woman, so bright, sharp, and she comes out with one of those, talking about radiation and stuff, and phones and Wi-Fi and how that's impacting on our health and our immune function, the stuff we talked about today. And so she's so bright. She discussed these crystals and stuff that you can buy for your phone, and things you can put around your phone, and questioned the efficacy of them because the phone still works.
Well, that's
So
I
you
do
do.
this question
Yeah.
too. And if they were so
Somebody's making a lot of money.
amazing,
Yeah.
wouldn't everyone have? They would just be. Everyone would know about them, and they'd be everywhere. And why is there only one small little?
I mean,
company
that's
producing it and
15.
not
That's
doing their own
15
marketing?
Australian dollars from a BP station.
Yeah.
You know,
That's it.
And it's It's good. It's good.
Yeah.
And it's much clearer when you're talking, and you know when you're on a mobile phone, you can feel your head gets really hot.
And my arm gets like really achy.
Yeah.
I start feeling, and sometimes I get numb fingers.
Yeah, there you go. That's exactly what it's. Yeah, that's what it's doing, definitely. And it's yeah. I mean, we're sleeping with our mobile phones beside our bed at night, and you know how many people are doing that. It's just these are things that we need to start rethinking again. It's not normal. It's not good for our brain health. Yeah. Same with our children. So. Right. When we've covered endocrine stress, so we've got either HPA axis. It's a bit of a mess, or we've got decreased HPA axis. Now, I think the most interesting thing about manipulating and restoring normal HPA axis is actually having a social structure. Having lab, having good support mechanisms, and we may all well have this in the room, I don't know, we may not, but there's a lot of people that will walk through your door that don't have that support structure. Yeah. Especially people with chronic fatigue, any psychiatric problems, because they've exhausted all the resources over time, and they end up living quite an isolated life. Yeah. So trying to work out, that's probably going to be the most challenging things actually. How can you support the HP axis through a support structure, and what is that support structure for them? I've spoken at a few chronic fatigue events, and a lot of them were sleeping, but because it's just don't have. I know we can laugh about it, but they don't have the concentration, and they're like swimming uphill through soup trying to get better, and they're doing it on their own often because they don't have the support structure around them. So that's one of the key things you can look at doing, is making sure that they are trying to work out how you can support that for them. Meditation, whatever that means for them, and then of course getting into herbs. Things like L-carnitine is a good amino acid that you can look at there. What was it? L-carnitine, acetyl L-carnitine. So we'll put that here. And then you've got N-acetylcysteine. There's a lot of research on NAC. NAC helps with that. Do you remember we talked about insulin resistance? The equivalent in the brain is glucocorticoid resistance. NAC is very useful at helping that.
So would you supplement with like a...
You can get NAC as a supplement.
Would that be best for somebody in this situation?
Yeah, definitely. It's not vegetarian because it's derived from goose and duck feathers, but it's very high in N-acetylcysteine. And N-acetylcysteine is a precursor to glutathione as well, so it's got a few things there that it's got that rare effect of treatment. So yeah. So those would be the key things to look at. So in terms of key concepts of take home today, is that chronic fatigue, fibromyalgia are all both neuroinflammatory conditions, and these are the 4 areas that you would work on, and these are the 4 things that you could start to embed into their daily dietary needs. So that's just a brief summary of what we've done. But you can go as technical as you want really with what neuroinflammation is. I think we've covered that today. You know it's a cytokine excess. So the brain is immune privileged. Okay, so under normal circumstances, it only has B cells in there. It doesn't have T cells. Okay, and probably the reason for that is because it would be in a constant inflammatory state. And so it's the B cells that manage that, so it's an innate immune response in the brain only under normal circumstances. except for head trauma, multiple sclerosis, Alzheimer's disease, schizophrenia, autism. You can see that inflammation in the brain. But when it comes to conditions like chronic fatigue, depression, fibromyalgia, it's like a para-inflammation. So it's not full-blown inflammation that you would see in those head trauma and psychiatric conditions. It's a grade down from that. Your ADHD is seen as a neuroinflammatory condition as well. Yeah.
I've had a few clients that had this condition, but they were all vegan. Can you maybe comment on this? Sometimes I wonder if they just don't get enough B12 protein.
But then you have to question their methylation pathways, and so methylation is a complex condition. It's a bit of a buzzword at the moment, but methylation is involved in every single cellular process that goes on in the body. So first you've got phosphorylation, and then you've got methylation, and cells can't function without it. And so in the likes of vegans, they are often B12 deficient. They're not necessarily getting enough green leafy vegetables into their diet. They generally have a high carb diet, but not the right kind of carbs. That's been my experience with vegans. Very few who are well managed with it, and food combining and protein combining and stuff. So yeah, I would be first and foremost looking at what are they not eating and what are they eating. Yeah.
But can you beat a condition like this? Staying vegan?
Can you beat a condition based? Well, yeah, because you're still going back to where's the systemic inflammation that's feeding into the neuroinflammation. So you're still looking at that as one of your primary treatments, is that it's a neuroinflammatory response, but why? Yeah. And I don't think we can say just because they're vegan they can't reach it.
I'm not sure they're just tired. I wouldn't say that they have inflammation.
They're just what?
They just feel tired.
They just feel tired. Have you checked their B12 and their folate levels?
No, you don't cut a blood test until later on.
Oh, well, see, that would if you've got a long-standing vegan, that would be the first protocol is you look at their B12 levels because your liver only stores it for 4 years.
Well, if you see that it's not in a diet, then you can almost assure that anemic.
Yeah, bound to be.
Yeah, exactly.
Yeah, so yeah, probably not chronic fatigue, they're probably just anemic. Possibly, I don't know enough about them, sure, but could you refer them to their doctor to get their blood done?
It seems to be a combination that it's,
There's certainly crossovers.
Vegan for a very long time.
Yeah, it's one of the common complaints of being a vegan is the anemia. Yeah. It was a B12.
With chronic fatigue, they're exhausted and
Yes,
tired.
that's right. Yeah. And it's going back to that flu-like symptom, when you're coming down with an infection yourself and you just feel so lousy and so tired that you think, I don't know how I'm going to manage to cook dinner for my family tonight. That's how they're functioning all the time. And the reason why we feel like that is because we've got an acute neuroinflammation as a result of the immune system trying to get on top of the virus or the bacteria, normally the virus. Yeah.
So, what would be, you said before that adrenal fatigue is kind of part and parcel? Did you say it was kind of connected to?
It's a spectrum.
Yeah, so is that kind of like early warning signs, if you will?
Can be, depends on the patient, because every patient is presenting differently, of course. So,
sure.
Kind of shitty warning sign, I have
but
to say.
yeah. But it's a sure. You don't have to have adrenal fatigue first to get chronic fatigue.
No, but
is
if
that
someone,
what you mean?
I just mean like if someone is presenting with adrenal fatigue, would following a model like this actually be quite beneficial as well?
Absolutely.
As well as specifically tailoring it to their needs and their symptoms they're presenting.
An adrenal fatigue patient usually have got really high potassium levels and really low sodium levels, and so certain foods can make them feel really bad. So high potassium, the potassium is in every food, it has to be, because it's a massive component of the cell. But it's, certain foods can exacerbate an adrenal fatigue patient as well. So it's just but they have this whole nocturnal diurnal rhythm of their cortisol. So they've got that cortisol awakening response that was mentioned in the presentation as well. So they're completely upside down. So they do present as a fibromyalgia patient, but they can also move into chronic fatigue or vice versa.
Yeah,
so
okay.
it's all adrenal fatigue, chronic fatigue, fibromyalgia are all on the spectrum. So you would treat it the same way.
Yeah, so I know a little bit about Asperger's and autism
Yeah.
in the spectrum and that,
Yeah.
kind of correlating it, like using that as a point.
Yeah. This
Cool.
is a good model to use for
Yeah.
autism as well. Yeah,
Right.
and schizophrenia, any psychiatric condition. Yeah,
Cool.
yeah.
Would you recommend further reading on this subject?
It's all in your slides, all the references. Yeah, it's huge.
But not a large book.
The thing about books is that they've condensed, they've taken the bits from here, there and everywhere, but there's a good book by James Wilson called Adrenal Fatigue. It's quite a user-friendly book, and it's got a little appendix thing at the end, a questionnaire that you can use. Michael Mays is probably the lead researcher in the world, but he's in your references there, he's in your annotation of references there. He works over in Victoria University, so he's done a lot of work around chronic fatigue.
What's his name?
Michael Mays, M-A-E-S.
What's this line about chocolate?
So not all chocolate is equal. So it's looking at various levels of cocoa powder in a chocolate, and so you're better actually just to go with cocoa powder, which is what I gave you there, and putting it into smoothies and stuff, which is really easy.
Sorry, I don't mean to sound absolutely stupid,
No, you're
but
not at all.
you keep mentioning powder. Is it?
Cocoa powder.
Yes, so but in its forms like the chocolate nibs, or in its more parabens or butter, or is that still beneficial, or it's got to be ground into powder?
Well, it's easier to get a powder in through food or in through a smoothie. Yeah, and you can use cocoa nibs, but getting people to eat cocoa nibs,
Oh, they're really good.
they're very, very good, but some folk just won't do it.
Okay, cool. I've just
That was
confirming
all. That was all. And you can use cocoa butter. I mean, these are high on antioxidant foods, so however you want to get them in. Yeah. Any other questions?
Krill.
Krill.
Looking fish oils.
Yeah.
Good, bad.
It's quite good for working through the lipoprotein A pathway for reducing cholesterol, and it's got anti-inflammatory properties in its own right, but it's not really linked to any mood disorders or any psychiatric type complaints. Yeah. It was a bit of a buzzword a few years ago, and it's just kind of died off now. I think you're. Are they?
Yes. Saying it's a better environmental.
Is it though?
Fish oils. Well, that's what they say.
I know. Gotta watch the propaganda. Yeah, even fish oils, you have to question the models around. You know, it's not really sustainable, is it? We're now encroaching into Southeast Asia and taking all their fish and leaving starving people. Just opens up a whole can of worms, doesn't it?
So what do you reckon to the fermented fish oil?
I don't know much about it actually. I haven't read much about it.
So green pastures.
Yeah.
That's one of the brands. There's a new one as well that's just come into New Zealand. The fermented slightly different ways. Green pastures one's good because it's good if you want to get it down to kids because it's chocolate flavour or orange flavour. They add cocoa to it. But they prepare it traditionally so it still contains all the vitamin A and D content and it hasn't been removed. And it's the fermented fish oils are the ones that are recommended by the Western price model for remineralisation of teeth and stuff like that.
Yeah. I haven't used it personally myself. I don't know much about it, so I can't comment, I'm afraid. Do like Western price though, and I've put slides, there's some slides there about what's, the 12 naturopathic principles, which are essentially diet, and diet. I think it'd be 12 diets in there. But it's looking at, okay, so we've got an apple. This is looking at Western Prices philosophy now. We've got an apple, and now we're going to poach the apple, and then we're going to puree the apple, and so it stops becoming an apple. And if you look at Western Price, it's the chewing of the apple, isn't it? And how it keeps your jaw muscles strong, and then those jaw muscles, if they're strong, it keeps your neck muscles strong, and then you start getting into chiropractic philosophy, so you're getting into structural stuff, and I think if we can have food in its most pure form is good, isn't it? And Western Price is a good resource for your patients, definitely. He's got a lot of wonderful information here, especially on the health of the mouth. And it's just phenomenal reading. If you haven't read it, you need to know the stuff for your patients. The downside of root canals and how they actually impact on poor health, and it impacts on your heart, and we've chosen a profession where we're never going to stop learning. We'll be students until we're in our 90s. But Western Price is, do they teach that here, the philosophy of Western Price? No, you just have to dig these things out yourself.
Myself, because I came across issues with surrounding cavities, and with my kids, unfortunately, after my eldest got whooping cough, and we treated him with vitamin C, which was great. It stopped the whooping cough, but it eroded on his back teeth. So I read up on Western Price and followed some of the principles there, and used the fermented cod liver oil and remineralised its stuff, and I was absolutely blown away, because we were told, once you've got toothpick decay, that's it, it's all over. And me being vegetarian most of my life, which I no longer really am now. Realising the whole impact of food and what it does to you, and just how if you're actually eating the right food, something that we've been told that you can't prepare, you actually can.
Yes.
I'd love to know more about that. I'll talk to you later about it.